Hello, good evening, everyone. It's a great pleasure to welcome you all for the day two in the management of lung cancer, the recent ELCC updates, and we have a pleasure to have both the organizing secretaries. Thank you, Dr. Amol Dungre, sir, for yesterday's wonderful, insightful presentation. And today, let me have a pleasure to welcome and invite Dr. Nikhil Pandey, a consultant medical oncologist, SCG NCHRI Cancer Center, Nagpur. So without wasting much time, I hand over the floor to Dr. Nikhil Pandey for further proceedings. Over to you, sir. A very good evening and welcome to all of you.
Good evening, everybody, and welcome to this recent lung cancer ELCC updates. Uh, it is difficult times, like we were just discussing with Gancham sir, that we are having COVID situation upon us, and it is not taking any time to go away. And in spite of this, it is so nice to see everyone participating, everyone coming forward and having some updates, because this is how I think it's our direction to go forward. And this is where, in in spite of the fact that we cannot meet in person, at least we meet each other on this platform. So this was the idea behind me and Amol sir's getting together this conference. And I'll just not talk too much, because the next session, in which the two speakers are there whom I really would like to hear, and I'm just matlab, taking time and getting them not to speak. So for the first talk, which is sponsored by Eli Lilly, I would ask Dr. Ghansham Biswas sir to speak about how talk on one size fits all, and what information will help improve our treatment decisions in advanced EGFR mutated NSCLC patients. Over to you, sir. Dr. Ghansham sir is the director and of Sparsh Hospital, Bhubaneswar, senior medical oncologist. Sir is very well informed, but at the same time, extremely down to earth. So over to you, sir.
Good evening, all. Thanks, Nikhil, and thanks, Amol. Thanks, Horizon, for hosting the meeting, and thanks, Eli Lilly, for the opportunity. So next. So we are talking about a mutated EGFR, we are talking about NSCLC, and we are talking about a treatment naive situation. So does one size fit all? So we are into a situation in 2021. So we are debating that probably we have different treatment armamentarium for a different EGFR. So what information will help improve our treatment decisions? Next. So this is the slide every medical oncologist knows. The first box is a first generation TKI. The second box is the second generation TKI, and the third one is the third generation TKI. So all the first generation TKI are compared with the chemotherapy backbone. We see that there was a modest responses, modest PFS, but none had an improvement in the OS. Coming to the second generation, so second generation was again against the chemotherapy, except the Archer 1050 with dacomitinib, which was against the first generation TKI. Again, so no much, yeah. So we can see that in the responses. So again, improvement in PFS, but again, no much in OS except a subgroup of a different EGFR in both Archer and in the Lux lung. Coming to the FLAURA, that was the third generation osimertinib, which was again compared with the first generation EGFR TKI. So we can see responses, again, a modest PFS. So there was around 7 months of OS benefit. Next. Coming to the first line TKI combination. So that was a single agent and TKI combination. So the first paper from our alma mater, Dr. Kumar Pravas and Banita. So gefitinib versus gefitinib with pemetrexed platinum. So overall responses improved, PFS improved, and we are yet to reach the median OS. But the trend towards improvement in the OS, and that was also true for the others, Japan and the Chinese trial. And we'll be talking more about this, the relay, what Dr. Amit will be talking about. So these were chemotherapy with, and this was anti-VEGF with first generation EGFR TKI. So improvement in responses, PFS, and we'll look at So what happened to the OS in the subsequent presentation? Next. So now we know that exon 18, 19, 20, 21. So these all are going to behave. So the upper one box, so 19 and 21 almost constitutes 89 to 90% of the EGFR lung cancer population, and rest 10 to 12% is contributed by 18 and 20. So today, if we try to segregate 19 and 21, it is just like a metastatic colorectal cancer. So we know that in metastatic colorectal cancer, left-sided tumors are better. So in the left-sided lung, so we'll get more of exon 19. In left-sided colon, we see a more of a younger population. So in exon 19, we'll see on the left-sided younger, while in exon 21, it is more in the right side and the older population. Next. So this is whole of 18, 19, 20, 21. We can see, so the majority we see is a exon 19 and followed by 21, and then rest is contributed by the 18 and 20. And this, we know that they are seen either in the never smokers or former smokers, adenocarcinomas, female, Asian group. Next. So coming to the indirect meta-analysis in the PLOS one, so 6 studies, around 1,400 patients. So these were compared first generation and the second generations. It was compared with the chemotherapy. So significant reduced risk of disease progression for exon 19 as compared to the exon 21, that was L858R, with the overall HR of 0.59 and a significant p-value. Next, coming to a direct meta-analysis, again in the PLOS one, 7 studies, around 550 patients. So first and second generation EGFR TKI compared with chemotherapy. Again, there was a significant reduced risk of disease progression for exon 19 as compared to the exon 21. Next. So coming to these important slides, on the upper half, you can see, so all this relates to exon 19 and the lower half relates to exon 21. So FLAURA, if you try to see exon 19, so the benefit of that osimertinib was 21.4 PFS, whereas with afatinib 13.8, and with the first generation EGFR TKI 11 and 16.5 with the Archer dacometinib. And in exon 21, we can see, so they have not fared like what exon 19 had. So 21.4 in the exon 19 with osimertinib, while in the exon 21, it was 14.4. And you can see with afatinib 10.8, with erlotinib 8.4, with Archer 1.1050, it was 12.3. So it means that in patients with exon 21 mutations, median PFS has yet to exceed 14.4 months, which was seen in the FLAURA with osimertinib. Next. So with afatinib, both the Lux Lung 3 and Lux Lung 6, if you take combined OS, again you can see the deletion 19 did better than the L858R. So overall survival was improved for patients with deletion 19. The absence of an effect in patients with L858R suggests that EGFR 19 is a different biological disease with L858R. We will see that L858R, that is exon 21, usually is less sensitive like the exon 19, and this in the around 40 to 60%. So 60% more co-mutations happens with exon 19 as compared to exon 19. So that's why, so they are biologically different. Next. Coming to the OS in the FLAURA, you can see a little better benefit in the L858R subgroup. Next. Coming to Archer 1050, so we can see a modest PFS 12.3 in the exon 21 subset as compared to 14.7 in the ITT population. Next. So coming to the relay, so the PFS in exon 19 and exon 21, we can see, so 19.6 and 19.4. So this is probably the highest what we have seen with the other anti-EGFR. Next. So coming to uncommon EGFR mutation, that is exon 18. Next, we know that till today the data favors afatinib. So overall response rate 2 out of 3 is going to respond to afatinib. If we have an exon 18, duration of response at 1 year is around 1 out of 2, and duration of response at 1.5 years is 1 out of 3. and probably second drug in osimertinib, though we have a response rates and PFS much lesser than afatinib at this moment. Next. Coming to exon 20, so probably this is a refractory EGFR at this moment. So probably some drug like poziotinib, which is a novel inhibitor of EGFR and HER2 exon 20. So probably it will in time to come it will have in practice. So overall response rate 55% and a median PFS of 5 to 5.5 months with a hard to treat disease in the EGFR sequence. Next. So to summarize, exon 19 deletion, so probably is usually seen in the left lung, younger patients, they have a less concomitant mutations and more sensitive. Historically, this subgroup has achieved better outcomes. Both third and second generation have demonstrated substantial PFS benefit. Exon 21, so which is the most discussion today. So median PFS had not exceeded 14.4 months, what we saw in FLORA with osimertinib. So promising results in the subgroup from RELAY with bevacizumab, with Cyramza and alutinib. Uncommon EGFR mutations. So at this moment, afatinib scores over osimertinib. Exon 20 at this moment, we have to go with chemotherapy till we have poziotinib in hand. Next. So first generation TKI followed by osimertinib in T790 mutations. So many a times affordability. So second generation TKI, most of us follows because we know that most of our patients cannot purchase the original osimertinib and osimertinib on progressions, and osimertinib in first line EGFR mutated non-small cell lung cancer attains the maximum, but again a costly drug, but definitely prevents brain metastasis. And for a young fit patients like the TMH trial, so chemotherapy with first generation TKI can improve PFS, OS, but at the cost of some amount of toxicities. And we are looking at a new combination of a TKI VEGF, especially for those patients with exon 21 mutations. Next. So this is the landscape of EGFR mutation and how we can sequence in future. Thank you so much.
Thank you, Ghanshyam sir. Thank you so much. It was such a wonderful talk listening to you. For the next part of the session, I would like to invite Dr. Amit Rothan. Sir is a HOD and Senior Consultant Medical Oncology at Manipal Hospital, Bangalore. And sir will be talking about relaying relay. Over to you, sir.
Thank you. Good evening, everyone. Thank you, Nikhil, and thank you, Dr. Amol, for having me here in this meeting. Can I share my slides?
Yes, sir, you can share it.
Yeah, thanks. Thanks. I also thank Lily for giving me this opportunity today. Okay, so here we'll. Yeah, so my topic is relaying the relay data, and what we are talking about. Relay, we know, is a randomized trial of looking at combination of ramucirumab plus erlotinib versus erlotinib alone in advanced EGFR mutated non-small cell lung cancer. So Dr. Ghanshyam has set the stage for EGFR mutation treatment and how we look about it and what are the factors we are looking at. There has been data that VEGF is important for EGFR mutation patients, and blocking VEGF has been a strategy which has been looked at. It started off with bevacizumab-based data, combinations with erlotinib were seen, and even ramucirumab has data of using as a combination with TKIs. Now, ramucirumab, we know, is a VEGF receptor 2 monoclonal antibody. So what happens is there. So this was the background of looking at a combination of Cyramza and erlotinib. And it was said that if you blocked VEGF receptor 2, you will be blocking all the VEGF's ligands. You will be blocking A, C, and D. And it was also thought that if you block the EGFR TKI, you're inhibiting tumorigenesis. So there is a synergism which is happening when you're combining both of these mechanisms. And with this, it was taken up in the RELAY study. RELAY was looking at stage 4 EGFR mutated non-small cell lung cancer patients, advanced disease with EGFR 19 and 21 mutations. This was used as a stratification factor, and it was randomized 1:1 between erlotinib and ramucirumab plus erlotinib. Now here ramucirumab dose is 10 mg per kg 2 weekly, treatment till progression or toxicity. The primary endpoint was progression-free survival, and secondary endpoint was looking at response rates, overall survival, safety, and duration of response. There was an exploratory endpoint of looking at PFS2. So both the arms were very well balanced in all the factors. About 60% of patients were never smokers in this trial, and 40% of patients had history of smoking. About 55% of patients had EGFR 19 deletion, and 44% of patients had the EGFR 21 mutation. Now, this is the results. Dr. Ghanshyam just showed us the results of RELAY. There was a clear improvement in the progression-free survival, which was the primary endpoint of the study. 12.4 months increasing to 19.4 months, clear hazard of 0.591. So it was a clearly significant trial, and it is a positive trial with its PFS advantage. What was important was were there subgroups which showed a difference. And it clearly showed us that all the subgroups showed benefit when you added Cyramza to erlotinib in comparison to erlotinib alone. Especially the question asked was, if you look at the two EGFR mutations separately, we know Dr. Ghanshyam just showed us that 19 does well, the exon 21s don't do so well. And he also showed us in all the previous studies, even with osimertinib as using as a single agent, the exon 21s, we got a median PFS of about 14 months. They were really not doing very well. But here what we see in both these arms, 19 and 21, we have an equally separation of the curves, the PFS going from 11 months to 19.4 months in the exon 21 subgroup, hazards of 0.44. And even in the exon 19, we are getting a similar benefit with the hazards of 0.65. Sorry, the hazards are 0.62 and 0.65 in both of these arms. So clearly what we are seeing, there's an advantage not only in the exon 19 subgroup, there's also an advantage in the exon 21 subgroup. The duration of response was also better, 11 months going to 18 months, which was statistically significant. The question is, when patients progress, we know in EGFR mutation patients, the T790M is the dominant mutation when you treat them with the first or the second generation TKI. 60 to 70% of patients develop it. In this trial, all the patients had not been evaluated for a T790 mutation, but the population which was evaluated, we saw that it's the same development of a T790 mutation, whether you treated them with erlotinib or whether you added erlotinib with Cyramza. About 43% and 47% developed a T790 mutation at progression, which could be targeted. There was a PFS2 which has been reported. The PFS2 is again significant, though the medians have not been reached. There is a separation of the curve which is shown. Now, PFS2 for us is important because nowadays we use a lot of PFS2s when we don't have the OS endpoints yet, using it as a sort of a surrogate for overall survival. But here what we saw clearly, there is a separation of the curve. PFS2 is showing a benefit of ramucirumab erlotinib versus erlotinib. But again, we still don't have the OS data. We don't have all the events which have happened. So the OS data is not yet mature for reporting. The other question which always comes up in the mind is, we are adding a VEGF inhibitor, what will be the toxicity? We know erlotinib is a very safe drug and all of us are very comfortable using TKIs, but what would happen if you use a long-term anti-VEGF monoclonal antibody? So this is anti-VEGF receptor monoclonal antibody. So that's the other thought, that would it be different and would adding this strategy increase toxicity? So we did see that there was higher grade 3 adverse events when you added Cyramza to erlotinib, 53% went up to 71%. But again, if you see the serious adverse events, 20%, 29%, not very different. And discontinuation of the study drug due to serious events, again, not very different, 10.7 versus 12.7%. So what was it which was causing higher toxicity? Now, the three toxicities which we talk of whenever we use a VEGF strategy, we talk of hypertension, we talk of proteinuria and bleeding. And the maximum worry of us for everyone who uses an anti-VEGF strategy is, will the hemorrhage and bleeding episodes be more? And will it complicate the matter in lung? Especially we worry about this. But what was seen here in the relay, that
Aram, I think we lost her in between.
Yes, sir, I think sir has network issues.
Okay. So can we get her back on?
So we can just call him, or we'll just wait for a minute. He will definitely join.
Yeah,
Yes, sir.
by that time, Dr. Amit joins actually. So I'll just share my experience. So I've started 2 patients on L858R. Both are elderly, EGFR mutated, and so both are on this regimen of relay. So at this point of time, 2 months are over now. The patients are doing well, except like the erlotinib toxicities. So I have now moved from 150 to 100. Otherwise, Cyramza, as we have used in lung cancers and others, so it is absolutely safe. So far, so maybe next month we'll be evaluating both these patients. And
So this is actually so true, because everyone, this is to join, put everyone on osimertinib and then forget about it, be it whatever mutation. And so we could, when we showed the data of 14 months, that time really showed that we should think differently.
Yeah, Dr. Amit has joined back, so we'll continue. Yeah.
Yeah, I'm sorry, I lost connection. Actually, I was in my second last slide, so I'll just present it off without the slide. If that's fine. So I was just talking of the toxicity. We had more hypertension, which is expected with anti-VEGF. Again, these are the ones which were the most important grade 3 events. 24% hypertension, and there was more proteinuria as expected. So there was actually no major toxicities more than what we would expect, except these 3 toxicities. So it was pretty well tolerated, even though we added Cyramza to erlotinib. So with this, I would like to summarize. Cyramza erlotinib significantly improved the median progression-free survival. We saw pre-FS going up from 12.4 months to 19.4 months by adding Cyramza, hazards of 0.59. We saw a consistent benefit in both the subgroups. Exon 19 is doing well, but even the exon 21s, which usually don't do very well, where we had a median PFS of 19.4 months by adding Cyramza to erlotinib. The safety is consistent with the established safety profiles, what we expect with a VEGF strategy. Again, no major bleeding episodes, no major issues in terms of adding added toxicity. The EGFR T790M rates at progression were similar between both the treatment groups. And definitely this is also one of the options to consider in treatment with EGFR mutated non-small cell lung cancers. Definitely we will have to learn where this will fit into our place for our patients, which patient subgroup will this be better, but there is a lot of leaning towards exon 21 kind of a subgroup. So with this, I would like to thank everyone. Thank you.
Yeah, thank you, Dr. Amit. Actually, before we lost, so I was discussing, I had started 2 patients on the relay, and both of them are presently doing good. So they are yet to be evaluation has to be done. So both have landed up with the erlotinib toxicity at this moment. So
Right.
the elderly male of 80 years who actually had a hemoptysis prior to starting of Cyramza. So I thought, should I start or not? In fact, on the day 10, by the time he came for the second dose, his hemoptysis also improved. So that was a clinical improvement.
Oh, that's excellent. That's really very good. And this was exon 21 patients. How did you choose
both these patients are exon 21. So they are typically on the relay only. So just to have a taste of the, or you can say the experience. So but both have moved to erlotinib 100 from 150 because lots of skin toxicity was happening.
Right, that's very interesting. Actually, that's the patient group we are also leaning towards. That exon 21 is where we will be thinking about it. Exon 21 and no brain metastasis. That's where we are leaning.
Yeah,
towards.
absolutely.
That's where we are leaning to. Yes, sir. Anyone would like to have any questions for Dr. Ghanshyam sir or Dr. Amit? Because we have 2 minutes. If there are no questions forthcoming, sir, I would just like to ask about it, sir. Whenever a new patient comes to you, what all do you offer as the first line regimen? So, to either one of you, sir. As in, suppose it's an exon 19 mutation, do you offer EGFR with, do you offer TKI with chemotherapy also as an option? And do you offer Cyramza with TKI also as an option?
So for us, I think for me, when I choose, I look at the 1921 and I look at brain metastasis. So if there is brain metastasis, then I directly go towards osimertinib. That's one thing.
Yeah.
Now, if I don't have a brain metastasis, then I am actually, I do use a lot of chemo plus first generation TKI. We have seen the results and we have seen our own patients doing very well for long term, and we are reserving the osimertinib as a sequence. So that's something that we are definitely doing for our patients in practice. But again, in the COVID era now, again, giving chemo, calling them for chemo is becoming a little tricky. So again, our inclinations are changing. Now, for the 21s is where we start thinking, should we do differently? And we keep thinking, should we do dacomitinib or should we do a combination of Cyramza and erlotinib? So I still don't have too much experience of Cyramza. Dr. Ghanshyam's patients, I think, are the initial patients where we will learn from such patients and such usage. So I think Dr. Ghanshyam's inputs will be good in this.
Yeah, so as Dr. Amit says, so only first generation TKI alone has no role. So definitely like the ALK inhibitors, ALK patients, no. So probably we need to do an MRI brain for EGFR also because 30% of these patients can have a brain metastasis. But at probably previous thinking was that this patient doesn't have much. So so once they have brain metastasis and if they can afford, so definitely osimertinib is the choice. Otherwise, young fit patients, so chemotherapy and any of these gefitinib is a good combinations. If oral, so my sequence is usually a second generation like afatinib followed by on progression, I go for the third generation. And these are the only two patients of L858R where we have started just to get a hang of this. So it is very early to say. Even last week, Tony Mock was not much in favor of the relay. So he said it is too early to say that 19 and 21 are means probably the relay. So these are each individual's perspective. So probably time will say so how things goes on.
That is so nice to hear, sir. But yes, relay the data looks very promising, sir. For the next session, which will be on ALK inhibitors, I would like to call on Dr. Bhavesh Poladia, sir. Sir is a senior consultant medical oncologist at Thangam Specialty Hospital, and he will talk on the landscape of ALK alteration in non-small cell lung cancer. Over to you, sir, and good evening.
Good evening. I hope my slides are visible and I'm audible.
Yes, sir.
Okay. So good evening to one and all, and thank you, Nikhil, and thank you, Amol, for giving this opportunity. So I hope I do justice to this topic. It's an important topic. Maybe I'll try to wrap up in 5 to 10 minutes. So the landscape of ALK alteration is very important in NSCLC. We should not miss this because I'll show you why. We know that the lung cancer in India is very high. These are the Globocon 2018 data. And same is the mortality. We lose almost 90% of them, hardly 5 to 10% survive for a long term. We know the world data also, almost 20% of the patient are lung cancer all over the world, with almost 2.1 million new cases. And the most important is NSCLC constitutes almost 80 to 85% of them. The 5-year overall survival data is not very good, less than 25%. And in stage 4 patient distant metastasis, it's much more worse. So it is almost less than 10%. but the disease has become better. We have tamed the lung cancer a little better with the knowledge of molecular markers, and the cartoon shows, the diagram shows the various molecular markers which we play with, and we see better outcome when we target these molecular markers. So very short background of ALK. The discovery of ALK has started in lymphoma, as we all know, more than 2 decades back. It is not only present in lymphoma, but it is seen in many other tumors. Our point of interest here will be for the lung, where almost 3 to 7% patients of lung cancer have EML4 ALK fusion mutation. So the discovery in lung has happened in last 15 years, 2007. And basically it's a gene rearrangement where there is a fusion of EML4 to ALK, and this causes activation of the protein synthesis. So we have seen a big evaluation from last 13 to 15 years, starting from 2007 till now. And we have seen first generation, second generation, and third generation ALK inhibitors coming in and showing in better and better effect. So this is what has happened when we have gone from first to second and second to third generation. The potency, the CNS penetration, as well as the ALK resistant coverage has improved. So we'll go one by one and we'll see how it has improved. So the first of the first line study is Profile 1014, the crizotinib study, where it was compared with the standard of care, pemetrexed and platinum, and PFS was the primary endpoint. So we see that PFS was achieved. It was a positive trial, and it made crizotinib as a first line in ALK positive NSCLC patients. So the improvement was almost by 4 months, chemotherapy 7 and crizotinib 11 months. Same thing was seen in ceritinib when it was used against chemotherapy. And we see the PFS was almost double. The chemotherapy remained at 7 to 8 months, and ceritinib improved almost 16 months. Then comes the third molecule, which is alectinib, and this is a nice global ALEC study where alectinib was not compared to the chemotherapy, which is a weaker arm, but to crizotinib, which is a better arm, and that time standard of care. And again, the PFS was the primary endpoint, and we see the updated analysis, a staggering difference between crizotinib and alectinib in first line, 11 months versus almost 35 months. Not only in all patients, but also in CNS positive, CNS metastasis patient, we see an improvement of 7 versus 27 months. So this is definitely a very staggering difference. I have never seen any TKI doing better than this. So if we compare all the TKIs in the naive patients, alectinib is a clear winner with a super PFS of almost 35 months. Brigatinib again was seen versus crizotinib, and we can see the PFS. This is a 2018 slide, but a recent update of 2020 has shown the after almost 25 months of median follow-up, the PFS advantage of crizotinib was 11, and brigatinib was almost 24 months. So it is still little less than alectinib. So what happens once the patient starts progressing on first line? So the progression is of two different types: oligoprogression, where we see local treatment, we do the local treatment and we continue the same TKI, or is a systemic progression where we change the TKI if patient is very symptomatic, and sometimes we continue TKI if the radiological progression is only there and it is not much troublesome. So what happens when we change to the second line, and we have multiple drugs in that, ceritinib, alectinib, brigatinib, and these are the three curves, and we can see the PFS comparison. So lorlatinib is a newer one which has come into the competition, and we can see that in alectinib, the around 8 to 9 months is the PFS, ceritinib around 5 to 7 months PFS, brigatinib here looks very promising in second line, almost 16 months of PFS, and lorlatinib we don't have a endpoint because it is not yet reached. So lorlatinib is a recent, this is a very nicely done study, phase 1, phase 2 study with multiple cohorts looking for naive patient, first line patient, second line patient, third line patient. So definitely this was a very nicely done study. It has been discussed a lot yesterday in the last speaker, by the last speaker. So I'll not go much into the detail of it, but I'll come to the conclusion slide of that it definitely showed a clinically meaningful benefit in patients who have received prior crizotinib and also second generation TKI. Not only in those, but also in TKI naive patient, it has shown a good benefit. Irrespective of the resistant mutation, it has shown a good response. The most difficult to treat, that is G1202R mutation, which is the most difficult. Even it has shown response in those patients, and those patients without detectable mutation also had shown a good response. And it is generally well tolerated. We know what are the common side effects which can happen, mainly the the lipid profile which is deranged, and we can keep a check on that and keep the TRAs and EAs under control. So when we come to the third generation, the only available data currently what we have is Crown study, where lorlatinib was compared with crizotinib, and there is a staggering difference again. The same 10 months PFS of crizotinib versus not achieved for lorlatinib, and probably we have to see whether it crosses the alectinib landmark of 34.8 months. So the PFS was good across all subgroup. Safety summary was not much different than what we have seen in the phase 1 and 2 trial, phase 1 and 2 study, and it had shown an excellent intracranial response of almost 82% with 71% complete response rate, which has not been seen with most of the TKIs in first and second generation. Safety profile was not much different what was seen in phase 1 and 2 study, and this supports the lorlatinib to be an effective first line therapy. So in summary, the targeting ALK fusion is clearly the standard of care. So we have to do the mutation analysis for all the patients. Second and third generation are more effective. They can treat the resistant mutation. It is used also in treating and preventing the CNS metastasis with a longer PFS and OS. Sequencing is a tricky thing. We have to learn slowly how to do it. And approximately 35% patients are going to get compound ALK mutation on the usage of lorlatinib, and probably there will be a big number of patients who will be mostly refractory to all known ALK inhibitors. Lastly, lorlatinib definitely has a unique side effect which we typically can manage easily. So it probably is one of the promising agent. So sequencing can be any of these options. My personal choice is alectinib, the last one, followed by lorlatinib and chemoimmunotherapy, where we can see an overall survival, we can easily cross 4 or 5 years. The answer to the sequencing probably will come from this ALK master protocol. This is a very nice study. We'll see what are the results of it. Every crizotinib is a standard arm, and then the second generation A, B, and C. Alectinib, brigatinib, and ceritinib, and then there is a progression. With each progression, they are doing an NGS, and they are studying the deep sequencing and ALK resistant mutation. So not last but not the least, but there are future in the future we have much more from the ALK. So not only in metastatic setting, but starting from the curative setting, there are studies undergoing for unresectable stage 2 or 3 NSCLC, where radiation is given with ipi-nivo. And yesterday a lot discussion was going on that EGFR and ALK, they do not respond to immunotherapy. Probably this study will tell us that immunotherapy also does equally good in EGFR ALK patients also. Not only in unresectable neoadjuvant, but even in adjuvant, alectinib versus chemo has been studied. Crizotinib versus observation is being studied for Alchemist trial, and crizotinib is also being studied in a neoadjuvant setting, whether it is showing any response or not. These are certain newer molecules, TQB3139. It is a combined ALK and c-MET inhibitor, which has a higher activity than crizotinib. Then standard chemotherapy plus minus toripalimab, that is anti-PD-L1. In recurrent disease, a national lung matrix is going on to see whether crizotinib is, how the crizotinib is going to work in those patients. Slowly the trend towards treating lung as an oligometastatic disease by using ALK TKI versus local treatment, or a combination of ALK TKI like brigatinib plus local consolidative therapy, or a SBRT plus ALK TKI. So probably in future we'll also treat oligometastatic disease of lung with curative intent. Then there are certain other molecules which are going to come, like Fortinib succinate in the second line, and it is very, very effective against this resistant mutation which I have mentioned. And in future, we'll also see combination of alectinib plus cobimetinib, how it works, ceritinib plus trametinib, ensartinib, and not to forget alectinib plus bevacizumab. The role of VEGF is not only in EGFR, but probably in ALK also, especially in brain metastatic patients. And post crizotinib, definitely we have two new agents. One I already mentioned, TKB3139. Brigatinib versus alectinib, who is the winner will come to know. And there is one more newer molecule called as alcotinib, which is going to be used in future. And beyond the second line, what we have, when we have exhausted most of our therapy or the first line therapy, what are the other things which are going to help us? So the ABCP type of a regimen where platinum, pemetrexed, atezolizumab and plus minus bevacizumab is being used. Pembro plus platinum doublet and LTKIs is used in recurrent setting. Alternate, very, very novel kind of a therapy which I have come across is an alternate trial, where post second generation LTKI, they are using an alternate regimen of using lorlatinib 8 weeks, followed by crizotinib 4 weeks. So they keep alternating lorlatinib and crizotinib, those patients who have progressed on second generation, and this goes indefinitely till the patient progresses. Again, use of everolimus with ceritinib, probably to overcome the resistant. Then brigatinib in post alectinib or ceritinib post second generation TKI. This is the ELTA2 trial. Brigatinib combination with MET inhibitor like binimetinib, and there is some new combination of ALK-ROS1 and FAK inhibitor with this APG2449. So I would stop with this. This is our hospital. This is my team, and thank you. I hope this was quite educative to you, and I hope that we can care the lung cancer much better. Thank you.
Thank you so much, sir. It was such a pleasure. You put it so succinctly, the whole landscape. It is quite a difficult topic and you put it very well. Any questions, please put it in the comment box, because we'll be running short of time. And I would again invite and not let Dr. Ghanshyam go again to his next talk on predictors of treatment of response in ALK positive metastatic NSCLC.
Yeah.
Over to you, sir.
Yeah, can you share my slides? So predictors of treatment response in ALK positive metastatic NSCLC. Next. So you have already heard from, already heard about this. So ALK positive disease is a distinct subset of NSCLC. So patients are more often a non-squamous histology, either a neighbor or a former smoker, relatively younger patient, females, and especially patients who don't have a EGFR or a KRAS mutations. So clinical characteristics do not always predict the presence of ALK positive NSCLC, but we see that these patients many a times harbor a asymptomatic brain lesion. So before starting the treatment, probably it is wise to have a baseline MRI brain. Next. So we have already seen these slides. So with first generation moving to second generation and third generation, the potency, the CNS penetration, and the coverage for ALK resistance goes up. Next. So the mechanisms of resistance can be an amplification of the ALK fusion, can be a mutation in the ALK kinase domain, and there are different bypass signaling. Next. So how do you select your ALK inhibitors? So based on the systemic activity, based on the CNS activity, definitely the safety profile and the resistance profile. Next. So coming to one of the paper which got published in Cancer in January 2012. So this was a correlation between the percentage of tumor cells showing an ALK gene rearrangement, signal copy number, and response to the first generation, that is crizotinib, in the FISH positive ALK. So the background was that FISH consistently showed rearrangement in less than 100% of tumor cells in ALK positive. Increased copy numbers of fused and rearranged signals also occur. And here correlations are explored between the percentage of ALK positive and signal copy numbers and their association with response to ALK inhibitions. The methods that 90 patients of ALK positives were evaluated, the percentage of positive cells, patterns of positivity, and copy numbers of fused isolated red or green signals are recorded. But 30 patients had received a crizotinib. Next. So the results increased isolated red signal copy number correlated with the higher percentage of ALK positive cells. Mean fused copy numbers was negatively associated with these isolated red signal copy numbers. So neither percentage of positive cells nor copy number correlated with maximal tumor shrinkages with crizotinib. So the conclusion of this publication was that the strong association between increased copy number of key ALK signals and percentage of positive cells are in ALK tumors is maybe a technical factor rather a biological factor. So in ALK positive tumors, neither the percentage of positive cells nor a signal copy numbers appears to be informative variables for predicting benefit from ALK inhibition. So this was a negative paper in 2012. So we'll move to 2021. So next. So before that, so yesterday we had a discussion on ALK positive and the PDL1. So PDL1 expression is positively associated with the presence of ALK rearrangement. So upregulation of PDL1 by the EML for ALK fusion protein can induce apoptosis of T cells through the PD1 and PD1 excess. Next. But what happened? Alectinib versus alectinib and atezolizumab did not improve responses, neither improvement in the PFS. Next. So lorlatinib versus lorlatinib plus evolizumab again did not either improve responses or the PFS. Next. So no, ceritinib alone was no better than ceritinib plus nivolumab. Next. So if you talk about the safety concerns, so the rash hepatitis was significantly high. So the combination of ALK and the various immune checkpoint inhibitors did not actually go the right way. Next. So moving from 2012, now 2021, this ELCC paper, which was a poster presentation from the Turkey group. So the predictors of treatment response in ALK positive metastatic NSCLC. Next. So this was a retrospective study. So evaluated the data of ALK positive metastatic NSCLC patients treated with an ALK inhibitor. So the clinical, pathological, and treatment data were assessed by a binary regression analysis. The cutoff value of ALK positivity rate in tumor cells to respond to the treatment by ROC analysis was also evaluated. Next. So you can see the baseline characteristics. So 68 patient, median age of 55. So 53% of them were male, and around 90% of them were true adenocarcinoma, and de novo metastatic disease in around 82.4%. Next. So treatment received before these patients, so most of us, what we do in India, so most of these patients before these reports were available, so more than 50% of the patients were started with the platinum combination chemotherapy before they were switched over to an ALK inhibitor. If you see the group, so ALK was more than 50% followed by crizotinib, and there was hardly any patients in the ceritinib. Next. So the results, median follow-up was 21 months, median overall survival was 39.2 months, and overall response rate here included CR plus PR was around 66.2. So cutoff level of ALK positivity ratio in tumor cells for the responses were 33%. So the binary regression analysis showed on the left-hand side, what are the predictive factors to response to ALK inhibitors? So you can see the gender. So females did better than the males. You can see the p-value, ALK positivity rate, so and the number of metastatic sites. So the non-predictive factors to response to ALK inhibitors was age, primary site, so left or right didn't matter. So adeno versus squamous did not matter. De novo metastasis did not matter. And the type of ALK inhibitor also did not matter. Next. So from this poster presentation, that concluded that positive predictive factors for response to an ALK inhibitor is a high ALK positivity ratio. So in 2012 paper, it was a negative, but this showed a positive. female gender did well, and those patients who are the less than 3 metastatic side, so they have done better. Next. Thank you so much. So we are already into the second wave. So I request and pray that all of us stay safe and sound. Thank you so much.
Thank you, Dr. Ghanshyam. Thank you so much. And thank you for staying with us. Without wasting any further time, I would ask Dr. Shruti to join. Only there is one question. If Dr. Ghanshyam or Dr. Bhavesh can answer it. What do we do if ALK and EGFR both are positive? Have you come across this situation, sir?
Pardon me?
ALK and EGFR both positive, sir.
So in my cohort of 300 patients, I had 2 patients of EGFR and ALK. So one of these patients died before the ALK inhibitors were available. So it was around 6-7 years. So that was a patient from Kumar Prabhas only. And the other patient who is a Jawan in the army. So we have discussed many times about this patient. So this patient is now 5 years plus. So he was started with gefitinib, and subsequently I added the ALK inhibitors. So 5 years down the lane, so now he had a brain metastasis and switched over to lonartinib. So this is one patient around 5 years now, so doing well. So we don't know. So the literature says that when there is a EGFR ALK, so probably ALK drives more than the EGFR.
Thank you, sir. Next, I would like to ask Dr. Shruti Kate. Madam will talk on outcomes of ROS positive metastatic lung cancer patients treated with crizotinib. Madam is a senior consultant medical oncologist and the HOD in HCG Nashik. Over to you, ma'am.
Thank you, Nikhil. Arham, can you put my slides, please? Thank you, Nikhil. Thank you, Dr. Amol, for this opportunity. And kudos to both of you for doing such a wonderful job. So I will just start. I know we are in a haste. So the topic given to me is outcome of ROS positive metastatic lung cancer patients treated with crizotinib. Next slide, please. So with rising population, the incidence of lung cancer in India is also rising. And these are the predictions from WHO for the next 2 decades. Next slide, please. Over the last few years, we have noticed that there is a paradigm shift in the way we are looking at non-small cell lung cancer now. And we are moving ahead from being histology-based treatment selection for patients to targeting oncogenic drivers. And this is definitely having an impact on the survival of these patients. Next slide, please. So ROS1 fusion gene, CROS1, it codes for a gene that is a receptor tyrosine kinase, very much similar to ALK receptor tyrosine kinase, and it can have multiple partners. Most common is the CD74, and it is quite an orphan or a mutually exclusive sort of molecular alteration. Next slide, please. If you look at incidence, it is approximately 1 to 2% of patients with non-small cell lung cancer are going to have ROS1 rearrangement. If you look at the Asian population or the East Asian population, because we have the data for that group, and the incidence may be up to 3%. Next slide, please. So phenotypically, the patients are quite similar to those who have ALK sort of molecular alteration, female predominance, Asian predominance, non-smokers, and adenocarcinomas. But definitely, the phenotype is not indicative of ROS1 positivity, and hence ROS1 testing should be considered in all eligible patients with advanced non-small cell, non-squamous lung cancer. Next slide, please. So we are familiar with the testing. The gold standard is the break apart FISH, and more so these days we are more comfortable with RT-PCR, because at the same time you are able to look for all the molecular alterations rather than doing the test subsequently. So like I said, this molecular abnormality is quite mutually exclusive, and supposing you find an EGFR mutation along with a ROS1 rearrangement, you need to check with the RT-PCR, and most probably you are going to find out that the fish was false positive. So this mutation is very much mutually exclusive with other molecular alterations. Next slide, please. So this is the largest study, and which established the role of crizotinib in ROS1 rearranged advanced non-small cell cancer patients. This is the updated result from the Profile 1001 study published in 2019 by Shaw et al. Next slide, please. So we know the Profile 1001 study, and this is the ROS1 expansion cohort. Patient number was 53. These patients were positive for ROS1 by local molecular profiling. PS was 0 or 1. There was one patient with PS2 as well, and stable brain metastases were included. Patients were subjected to crizotinib 250 mg BD daily. And the endpoints were objective response rate, duration of response, time to tumor response, PFS, OS, and safety. Next slide, please. So majority of patients were female, age less than 65, quite well distributed, white as well as Asian population, good PS, never smokers, adenocarcinomas. Next slide, please. So these are the overall survival curves. So 1 year overall survival rate was 79%. Median overall survival was 51.4 months, and 4-year OS was 51%. If we look at the median follow-up, with this updated result, it goes as high as 62.6 months. The longest study, the largest study, which establishes the role of crizotinib. Next slide, please. So overall response rates were 72%. Median time to first tumor response was around 7.9 weeks. So quite good time to first tumor response. Duration of response was 24.7 months, which was actually increased in the updated Profile 1001 study with the larger follow-up. And median PFS was established as 19.3 months. Next slide, please. So irrespective of the partners for ROS1 fusion, the responses were quite well established. Next slide, please. But individually, the number was less for each of the fusion partner, but it is still established that it is the responses are irrespective of the fusion partner. And like I said, the median PFS was quite similar as compared to the first results of the profile study, and this is approximately around 62 months of follow-up. Next slide, please. So median duration of response, which was initially put up as 17 months, has increased to 24.7 months. Next slide, please. So the treatment-related adverse events were quite predictable. We know this molecule, grade 3 TRAEs were quite low. Serious grade 4 and 5 were almost none. And next slide, please. So most common treatment-related adverse events were vision disorders, nausea, some diarrhea, vomiting, and grade 3 side effects were hypophosphatemia and neutropenia. Next slide, please. There were no discontinuation because of the treatment-related side effects. So the updated Profile 1001 study, crizotinib is associated with median OS of 51 months in patients with ROS1 rearranged advanced NSCLC, and OS did not differ as according to the ROS1 fusion partner. Updated PFS, ORR are consistent with previous results with no new safety signals. Next slide, please. This is the UCROSS study, which looked at the efficacy, safety of crizotinib in the European population. Next slide, please. So median PFS was 20 months, and there was a trend of improved ORR and a longer median PFS when the partner was CD74, which is actually the most common partner for CROS1 gene, fusion gene. And they actually came up to say that TP53 co-mutant patients had a shorter median PFS as compared to wild type patients. So something of prognostic value. Next slide, please. Recently, the data of crizotinib in ROS1 patients has come up for the East Asian population. Next slide, please. So the ONC study designed quite similar to PROFILE. They did include brain metastasis if they were asymptomatic or treated or stable for at least 2 weeks, subjected to crizotinib 250 mg BD. And again, endpoints for primary was ORR, secondary being the treatment, time to treatment response, duration of response, PFS, OS, safety, and quality of life. Next slide, please. So
Madam, I just request you to.
Just a couple of slides. So PFS was quite matching, overall response rate of 90%. Next slide, please. So similar conclusions and good quality of life control, quality of life results with crizotinib. Next slide, please. Around 18% patients did have brain metastasis, but intracranial responses were not something that they analyzed. So this is the largest study for East Asian population. Next slide, please. So many new drugs also, which have been approved based on phase 2 data, but we know this molecule and we have the largest follow-up available. Of course, we know the limitations of this molecule, and patients with brain metastasis, you may opt for other drugs like entrectinib or lorlatinib. So with this, I will say thank you again.
Thank you so much, ma'am. Thank you. So in the interest of time, if any questions, please put it in the question box. The next we will start a stage 3 NSCLC. And for this, for the first talk, I invite Dr. Jayant Gavande. Sir is a consultant medical oncologist at Aditya Birla Hospital, Pune. And he will talk on Pacific R, that is the real world characteristics of unresectable stage 3 NSCLC patients treated with durvalumab. Over to you, sir.
So good evening, everybody. I hope my slides are visible.
Yes, sir, they are.
So at the outset, thank you, Amol. Thank you, Dr. Nikhil, for giving me this opportunity. I will be speaking about the early results of the Pacific R trial, which evaluated the real-world characteristics of unresectable stage 3 NSCLC patients treated with durvalumab after chemoradiotherapy. So based on the phase 3 Pacific trial data, we know that treatment with durvalumab for up to 12 months is now, which is known as the Pacific regimen, has become the standard of care in patients with unresectable stage 3 NSCLC who have not progressed following the initial platinum-based chemoradiation therapy. This trial has shown a 4-year overall survival of almost 4 years. However, insights on the treatment and clinical outcomes for patients receiving immunotherapy in a real-world setting are needed. So to assess the effectiveness of durvalumab in this patient population in a real-life setting, the Pacific R study enrolled patients who had received durvalumab in an extended access program, which was initiated by AstraZeneca, who has this molecule of durvalumab. So the baseline characteristics of the full cohort of patients enrolled in this Pacific R study, as well as the preliminary safety data, was reported in the ELCC this year. So according to the study design, patients who are eligible had to have unresectable stage 3 NSCLC regardless of their tumor PD-L1 expression, and they had to have no evidence of disease progression following either definitive or sequential chemoradiotherapy. These patients were started on durvalumab at 10 mg per kg given intravenously every 2 weeks. The data were extracted from patients' medical records for retrospective data collection at different time points. So this is basically a 5-year observation study to evaluate the disease evolution, and this is an ongoing study. The primary endpoint is investigator-assessed PFS and OS. The key secondary endpoints are demographics, disease characteristics, prior therapy, PFS and OS by subgroups, and adverse events of special interest. So coming to baseline characteristics, 1193 patients were enrolled in 254 active sites in 10 participating countries. Out of this, 1155 patients were found to be eligible and were included in the FAS, that is the full analysis set. So the participating countries were France, Australia, Netherlands, Belgium, Italy, Israel, Germany, Norway, UK, and Switzerland. Most of the patients were contributed from France. The notable baseline comorbidities were hypertension, seen in 30% of patients, COPD seen in 25% of patients, diabetes and cardiovascular disease, each seen in around 12 to 13% of patients. This is the first important highlight of this real-world data, which showed that 76.8% of patients received concurrent radiotherapy, but there were 14.6% of patients who received sequential chemoradiotherapy as against in the primary trial, and 8.6% of patients received treatment as an other regimen. If you look at the total FAS population, which is listed in the last column of this table, the median age was 65 years. Most of the patients were male. 65% of the patients were former smokers. Majority of the patients, that is 95%, had a stage 3 NSCLC as their initial diagnosis, and more than 50% of patients, that is 57.5, had adenocarcinoma as their histology. If you look at the concurrent and the sequential chemoradiotherapy cohorts, there were no significant differences in the baseline characteristics except for two things. More patients in the sequential chemoradiotherapy arm had an age of more than 70 years, 37% versus 28%, and more patients in the sequential chemoradiotherapy arm had a primary tumor diameter of more than 7 centimeters, 25% versus 15.8%. So this basically reflects how we treat these patients in the real world as well. Additionally, 68.6% of patients were tested for PD-L1 expression. Majority of the patients had a PD-L1 expression of at least 1% or more, as compared to 17.4% of patients having a PD-L1 expression of less than 1%. 10% of patients' PD-L1 expression was not clearly reported. There were no significant differences in the baseline characteristics by the PD-L1 expression level as noted. Coming to the CRT regimens by country, the median total radiation therapy dose was 65 gray. The median total RT duration was 6.4 weeks, which concurred with the standard treatment. The second important highlight of this study was this, that the median time from completion of radiotherapy to the start of durvalumab treatment was 52 days. That is, in the real world setting, there was a delay in the start of durvalumab treatment after radiation therapy. The platinum-based chemotherapy radiation regimens also varied by country. Vinorelbine was the favored partner in France, Germany, and UK, while paclitaxel was used more in Australia and Israel. Etoposide was the most used option in Netherlands, Belgium, and Norway. The median chemotherapy duration was 7.1 weeks. In Italy, it was noted that the proportions were similar between concurrent, and in Norway, it was mandatory that all patients had to have received concurrent chemoradiotherapy. So the predefined adverse events of special interest occurring in the first 3 months of durvalumab treatment were as follows. The most common, as noted in the primary trial, was also pneumonitis, which was seen in 10.6% of patients, and almost 4.8% of the patients had to have a permanent discontinuation of their durvalumab treatment because of this side effect. Endocrinopathy was another noted side effect seen in 6.8% of patients, but this was unlikely to result in permanent treatment discontinuation. So to conclude, this real-world study highlights two important differences between the real-world population and that seen in the Pacific. In the real world, more patients are likely to receive a sequential chemoradiotherapy than concurrent chemoradiotherapy, and there is likely to be a more delayed time to durvalumab start from completion of chemoradiotherapy in the real-world setting. This is important because exploratory analysis of the Pacific trial highlighted that patients who start treatment with durvalumab within 14 days after completion of radiotherapy have improved efficacy outcomes compared with those who start treatment more than 14 days from the completion of radiotherapy. But however, there is a French study of around 600 patients which showed that despite a delay in the start of durvalumab treatment, there was no impact on the survival outcomes. So we'll have to wait for the results of this study, and if we have the similar results, then it will give us confidence in treating these patients with durvalumab in the real world setting. Pneumonitis was the most commonly reported adverse event of special interest in the first 3 months of this treatment, which was observed in around 10% of patients, leading to permanent discontinuation in about half of the patients experiencing this adverse event. And we have to be careful about this side effect. So the future analysis of this ongoing study will focus on PFS, OS, and the duration of durvalumab treatment. Thank you.
Thank you so much, sir. Thank you for such a wonderful insight. I would like to ask Dr. Vaibhav Sonwani. Sir is a senior consultant in Department of Radiation Oncology at HCC Nagpur. He will talk about impact of PTV on progression-free survival in inoperable stage 3 NSCLC treated with chemoradiology. Over to you, sir. Any questions for Dr. Jain? Please put it in the question box or in the chat box.
Nikhil, am I audible?
Yes, sir.
Yeah. So thank you very much, Nikhil, for providing this opportunity to discuss the small paper that was published for this current the Lung Cancer Congress. Can I have my slides, please? Yeah. So basically, the inoperable locally advanced lung cancers. This is the most important statement that I would want to make, that the concurrent chemoradiotherapy, there is a reduction in the risk of death at the end of 2 years as compared to a sequential chemoradiotherapy, which is a 7% reduction as compared to the radiotherapy alone. So in clinical practice, unless there is a problem with the patient, the concurrent chemoradiotherapy should be the standard of care in such patients. Next slide, please. So based on that, there was a small study which was done by the same group who had published this paper that we are going to be discussing. So they they looked into the association of a planning target volume with patients' outcome in inoperable stage 3 lung cancer, which was treated with chemotherapy. Next slide, please. So the study revealed that the PTV basically the primary tumor and the lymph node which is involved, not the elective nodal irradiation, is an important prognosticator factor in the patients with inoperable stage 3 lung cancers which receive conventional radiotherapy. Basically, multiple parameters were looked in, but the most important parameter which came out was the PTV. So patients who had PTV more than 700 cc represented a special subgroup with a significant lower locoregional control, and with a worse PFS and overall survival rate. So this study basically recommended evaluating PTV as an additional stratification factor in clinical trials of a multimodal therapy in inoperable lung cancer. So this multimodal therapy part, where we were just using chemotherapy and radiotherapy, this is where the new immune checkpoint inhibitors had come and were also enrolled into offering treatment to the patient. Next slide, please. So is the graph visible?
Yes, sir.
So if you look at the graph onto your left and onto the right, onto the right is the overall survival, the progression-free survival, and the locoregional failure survival. So they are much better in the arms which received concurrent chemotherapy as opposed to patients who received just radiotherapy and followed by a sequential chemotherapy. Onto your right, it is the T stage and N stage match graph, similar to what we are seeing on the left. Next slide, please. So this is the study that we need to be discussing here, is the impact of the PTV on the progression-free survival in inoperable stage 3 lung cancer, which were treated with chemo, immuno, and radiotherapy. Next slide, please. Next. So this study, can you go back, please? The previous slide. Yeah. So basically, this study had evaluated use of checkpoint inhibitors also along with the standard chemotherapy. Next slide, please. So prospective data of 33 consecutive patients with inoperable stage 3 lung cancer, which completed chemotherapy with sequential durvalumab or concurrent and sequential nivolumab were analyzed. So different cutoffs for PTV were evaluated, again similar to the previous study, and look for the association with the PFS survival. Next slide, please. All patients received at least 6 gray of radiotherapy. That means basically 30 fractions of radiation, which went on for 6 weeks. There were patients who have actually received 64 gray also. Most of them had received 2 cycles of concurrent platinum-based chemotherapy. That is from day 1 and day 21. Median follow-up for the entire cohort was 20 months, and the median overall survival was not reached. The median PFS was 22 months. Next slide, please. In this study, patients with PTV more than 900 cc had a significant shorter PFS as opposed to what we saw in a concurrent chemo-RT arm, which was 700 cc. So it is in a range of 6.9 months versus 22.8. And the extracranial metastasis-free survival also was poorer in these patients. Furthermore, patients with PTV more than 900 cc in specifically stage 3C disease had even worse PFS as compared to the other in subgroup. Next slide, please. So the conclusion, PTV has a significant impact on the PFS and the EMFS after the CRT combined with concurrent or sequential checkpoint immune inhibitors. Patient with PTV more than 900 cc had a significantly shorter PFS and EMFS. Next slide, please. Next. So legal entity responsible for the study were the authors. Funding was not received. Basically, it was a research grant funded to the institution itself, and all the authors have declared no conflict of interest. Next slide, please. So this graph that we're seeing again on the right and onto my left and onto our right is basically the overall survival, the progression-free survival, and local region field survival in these studies which have used durvalumab as a adjunct following chemo-RT. So it is clearly visible that the arm which received immunotherapy following chemo-RT did better as opposed to the ones who just had chemo-RT. Next slide, please. Thank you.
Thank you, sir. Thank you for such a wonderful talk, and probably would interest us in using NACT prior to using CTRT for those with a very large PTV. Probably. So, just a question for thought.
Yes. So these days we actually can import the images onto our system, and even before we say it is large volume, we actually can draw the contours and figure out what is the volume. So I think it has to be individualized. It cannot be like the volume is such large volume and we cannot. Should not be the thought.
Yes, sir. Thank you, sir. I'll move on to the next presentation. It is by Dr. Sachin Gupta. Sir is an associate director at Max Super Specialty Hospital, Mohali, and he will talk on the evaluation of the of PD-L1 expression after combined radiochemotherapy in patients with stage 3 NSCLC. Over to you, sir.
Yeah, thank you, Dr. Nikhil, and thank you, Dr. Amol, for giving me this opportunity. We are slightly late, and I try to finish in time. Interrupt me if I'm, going ahead of time. And I want to share my slides. Okay. So can you see my slides?
Yes, sir, your slides are visible, sir.
Yeah, great. So this was an abstract in ELCC, evaluation of prognostic significance of PD-L1 expression after combined CTRT in stage 3. So previous couple of talks were about CTRT in stage 3 lung cancer. So building upon from there. Now the presenters was Dr. Jan Wagner. This is from Germany, and the authors are listed here. Now, just to give the background for this abstract, so this is a corollary from Pacific study. Now, Pacific study we know is a landmark trial which showed that patients with locally advanced unresectable stage 3 non-small cell lung cancer. So CTRT was done, and followed by that durvalumab was used. So which is a PD-L1 inhibitor. So this was compared with placebo. Now, in the updated and the final results of this study, it was seen that effect was limited to patients with PD-L1 expression of more than 1%. Now, if the expression was less than 1%, no benefit was seen, and it was partly due to the fact that the outcome in the control arm was surprisingly favorable. So it was speculated that lack of PD-L1 expression confers a favorable outcome after CTRT. right? So this was the background to which now they wanted to address this question, that whether this prolonged OS in the control group, so not in the durvalumab arm, but in the control arm, which lacked PD-L1 expression, so whether it is reproducible. So they analyzed their own this OS in a group of 101 patients with stage 3 non-small cell lung cancer who were treated with CTRT. So they took the the cue from the specific trial and did their own study. And PD-L1 expression was evaluated retrospectively, and the outcome in the group of PD-L1 less than 1% and PD-L1 more than 1% was subsequently compared. So now just to recollect what happened in the Pacific trial. So we will just spend few seconds on this. So stage 3 above 18 years, PS good, durvalumab for 2 weekly for 12 months versus placebo. And so it was given 1 to 42 days after post CTRT. And these responses and PFS and OS were studied. So the updated analysis, so at 24 months, we had seen 66% versus 55% patients were alive. Excellent results, so which have not been replicated so far by any other drug. Now, this durvalumab consolidation after CRT continues to demonstrate durable PFS and sustained OS benefit in this pre-planned exploratory update at 4 years. So median OS for durvalumab was 47 months, and in the placebo arm, it was 29 months. So 4-year OS 49%. So nearly half of the patients were alive at 4 years versus 36% on the placebo arm. Now, so when we compare the PD-L1, this stratification here, in the original study, it was the stratification was more than 25% PD-L1 status versus less than 25%. And also we have to note that nearly 37% of the randomized patients had unknown PD-L1 status. So it was not studied in nearly more than 1/3 of the patients. So in the overall study group, the HR was in favor of durvalumab. And if we substratify according to more than 25 versus less than 25, again, it was in favor of this durvalumab. Now there was a post hoc analysis where it was asked to substratify according to PD-L1 more than 1% versus less than 1%. Now here it was seen that if the PD-L1 population less than 1% was seen, the placebo arm was doing better here, right? Now for durvalumab in US and for our DCJ approval also, PD-L1 status is not required, but the European agency is asking for whether the PD-L1 is more than 1% versus less than 1%. So that difference is there. Now, in this particular abstract, so they did their own study. And so if the PD-L1 expression was not evaluated, so available samples were again evaluated for this. And also age, gender, histology, smoking status, performance status, albumin, CRP. Now, this is another marker they are doing here. And PFS OS were studied. Now, they showed that the expression of PD-L1 is independent from gender and histology. Median OS for less than 1% was 27 months and more than 1% was 19 months. However, it was not significant. Then median PFS also 9 months versus 10 months. This was also not significant. So they found that CRP values were actually, having a significant impact on OS with 27 months for low CRP and 17 months for high CRP. Maybe we can start looking at this marker for prognostication. But other clinical parameters did not impact the OS. So this was their outcome of 101 patients of stage 3 non-small cell. So they concluded that the assumption that the lack of PD-L1 expression confers good outcome versus more than 1%. So they did not actually prove this. So it was not justified in their 101 patients, which was there in the, let's say, Pacific trial. Now I have jotted down few more studies and meta-analysis. So this is a prognostic value of PD-L1 So here they studied CD8 plus tumor infiltrating lymphocyte density also. So this is again locally advanced non-small cell treated with CTRT. Now this was again retrospectively assessed these clinical characteristics, and 31 inoperable patients were there. And so they again studied PD-L1 expression 0 versus more than 1, and CD8 plus density 40% less or 41 to 100%. Coming to the outcome. So these showed that PD-L1 expression less than 1% was associated with improved OS and PFS, right? And a trend towards improved OS and local control with low CD8 plus density. So evaluation of tumor immunity in microenvironment appears to be an independent prognostic factor for this. And so they have further stratification of type 1 versus type 4. So where PD-L1 negative and CD8 low were doing better, and PD-L1 positive, CD8 low were doing the worst. So according to this, PD-L1 and CD8 plus can be studied. Now this is a meta-analysis of 50 studies where clinico-pathological and prognostic significance of PD-L1 is studied by ISC. Now they are showing that high PD-L1 expression was significantly associated with poor OS, right? Now here cutoff is 5%. And PD-L1 expression was associated with males, with smokers, with poor tumor differentiation, larger size, positive lymph node, and KRAS mutation, and EGFR wild type. Now this is another paper where again prognostic value was studied in stage 3 non-small cell lung cancer treated with chemoradiotherapy. This is about 117 patients, and so this 1% versus or 50%. So these were the cutoff used. So patients with PS0 and who receive more than 60 grays of radiation to OS significantly better OS. So they showed there was no difference, whether it was more than or less than 1% or more than or less than 50%. So this paper showed PD-L1 value doesn't, is not a predictor. Now this is again a review of literature of many studies. Now 35 studies were taken here, and immunohistochemistry method was the most frequently method used for PD-L1 assay. So again, the study evidence did not support an association with PD-L1 expression in gender, age, smoking, tumor histology, PS, grade, EGFR. In several studies, high expression was associated with shorter survival. But they consistently found that the most of the studies showed that high versus low PD-L1 expression were more likely to experience treatment benefit with the anti-PD-L1 drugs, so which are nivolumab, pembro, durvalumab, atezo, and avelumab. And so there is a lot of variability in the methods used to determine PD-L1 expression. So this is about my talk. I can stop sharing. So still there is no final answer to whether this PD-L1 expression less than 1 or more than 1, less than 5, more than 5, less than 25 or less than 50, more than 50. So this is still to be answered. And again, the assays being used are there are too many. And so somebody is using DECO, Ventana SP142, Ventana SP263. So there is a lot of variability in the methods of testing this, and a lot of variability in the cutoffs. So the final answer is still not there. But Pacific being the largest trial for this, and less than 1% versus more than 1% appears to be a good cutoff to my mind. So what I could gather from reading all this. So maybe we can stratify there whether to use durvalumab in stage 3 non-small cell lung cancer post CTRT. Thank you.
Thank you so much, sir.
Yeah.
Again, in the interest of time, I would ask Dr. Bharat Vaswani to start the next session, which is oligometastatic disease. Sir is a senior consultant medical oncologist at Yashoda in Hyderabad, and sir will talk on the brain metastasis in non-NSCLC in era of molecularly driven therapy. Over to you, sir.
Good evening, Nikhil. Thank you. You have to stop screen sharing so that I can share my screen.
Aram, can you take over?
Let me thank Nikhil, Amol, Nikhil, my younger brother, for a kind invite. I have been given 7 minutes time. So I have made 8 take-home messages, 8 slides only, 1 radiation slide, and on a Monday morning practice. So the topic that I am discussing in the next 7 minutes is brain metastasis in non-small cell lung cancer in the era of molecularly driven therapy, or how do I treat my brain metastasis in this era. So the first take-home message is, in a pre-TKI era, if you look into the incidence and prognosis of the patient with lung cancer, please concentrate on the left part, the blue graph. So around half of the patients, so the highest incidence of brain mets de novo as compared to other cancers is in lung cancer. And equally similar amount of patients can develop lung mets in the due course of time. Now, when you look into the second part of the thing, the cancer with a worse prognosis in de novo brain mets in the era of pre-TKI was lung cancer. So the first take-home message for everyone is, overall survival in lung cancer patient with brain metastasis was poor in the era of pre-TKI. Now, when you look into the brain metastasis in 2 categories, one non-oncology driven cancer and oncology driven cancer. What is more obvious about it is there is twice to thrice incidence of de novo brain mets on admission or on presentation in those who have a targetable drug mutation. If you look into EGFR, it is 30 to 60%. And when you look into ALK, it is 40 to 70%. So 5 to 7 out of 10 will develop brain mets in the lifetime. So the second take-home message is brain metastases are more common in onco-driven NSCLC. $1 million question: chemo or TKI in the patient with brain mets? So only one study that has directly looked into the asymptomatic brain mets is a Lux Lung 3 study. So if you remember that study, afatinib upfront versus pemetrexed cisplatin. Now, when you look into the overall PFS, 13.7 versus 8.1. Now, when you look into those with a brain met, these PFS was still more impressive only. So reduction in the risk of progression by 48% when you give TKIs versus chemo. So the third take-home message is TKI has to be preferred over chemo in patient with brain mets. Now, there was a discussion between Amit sir and Ghanshyam sir. Is there a role of first and second generation TKI in those with a brain met? Because what all we know is osimertinib gives you near excellent responses, probably better than systemic. Again, concentrate on the left side of my curve. Now, when you look into plasma concentration and CNS concentration, what is obvious in erlotinib, pulse erlotinib, which is 1500 mg per week, gefitinib, afatinib, there is a respectable CSF concentration, not as much as plasma concentration, but a respectable. And if you look into this is a very impressive thing. Is it translated in clinical practice? These are all retrospective studies. But if you look into intracranial response rate, around 50 to 80%, these are not bad. If you don't have a osimertinib, you are justified in giving your first and second generation TKI. And when you look into the PFS, 8 to 11 months. So when you look into osimertinib, this is something of like 4 times CSF concentration as compared to plasma in osimertinib. So the fourth take-home message is, having a third generation TKI, it is good, but even if you don't have it, you should give your first or second generation TKI because the response rates are between 50 to 80%, and more importantly, the PFS is between 8 to 11. Your overall PFS remains around this only. So you are justified in giving your first and second generation. Coming to osimertinib. When we talk about osimertinib, when you look into the pre-studies, which were pre-treated patients, that is AURA2 studies, a very impressive response rate of 40 to 70%, a CNS duration of response of 8.9 months, and more importantly, close to 1 year in a pre-treated patient. And when you look into the subset where they have combined both of them, the overall response rate was 54%, but that is not important. The disease control rate was 92%. So this is something of a magic. 9 of the 10 will have some sort of a CNS response, either a PR, maybe a CR, but more importantly, a disease control rate of 92%. So the fifth take-home message is osimertinib retains impressive CNS activity in heavily pretreated patients. Now comes the important thing. In a first line, These responses, if you look into FLAURA, try to concentrate on FLAURA, a subset of patients, around 62% of the 62 patients, that is 22% of the patients had stable CNS meds which were taken on FLAURA as compared to first and second generation TKI. Three important things. If you look into the response rate, 64% response rate as against 45. But try to concentrate on the curve. Nearly 90% disease control rate on only 2 patients, if you see, had progression. So nearly 90 to 95% of disease control rate. Now, when you look into progression-free survival, it was 13.9 with first and second generation, that is SOC. But if osimertinib, it has not been raised. So if you see the overall PFS, it was 18 months. And when you look into CNS PFS, it could be even more than that. So just telling that this impressive activity is better than probably a plasma activity. Now coming to the duration of response. This was 18.7 months in first and second generation, but it has not been reached with osimertinib. Again, telling that probably this CNS effect of osimertinib is something which is probably better than a plasma also. So the 6th take-home message for this is osimertinib is a treatment of choice as first line in patients with de novo CNS mets who are mutant EGFR. Only EGFR TKI have this response, or what about ALK? So there were a lot of discussion. Just try to concentrate on crizotinib. 23% intracranial response, 8% complete response. But this is something of like 81% response rate in a second generation with 38% complete response. Brigatinib, 11% complete response. And when you look into lorlatinib, 82% intracranial response, but 71% complete responses. You can never imagine 7 of the 10 patients that cranial disease will disappear with TKI. These are far more impressive than EGFR, but yes, you can still go ahead and give it lorlatinib and you believe that 7 of the 10 patients will have disappearance of the CNS disease. So the 7th take-home message for you is TKI has very impressive responses in terms of its CNS efficacy, PR, CR in case of amplified ALK disease. After all these discussions, is there a role of radiotherapy in this? Because you have so good TKI. So the answer is yes, definitely a big yes, but only in symptomatic CNS mets. That too, the recent data suggests that the modality which really gives you a OS advantage is the SRS. Against whole brain RT, against delayed RT, against no RT, if you can see. And the second most important thing is if the extracranial burden is minimal, that is 0 to 1, you have the best responses. So combination of RT will delay CNS progression. Concurrent with the TKI has been feasible. More importantly, the modality of treatment that you use, that is SRS, probably is better. If you remember your FORT study, a whole brain RT in an advanced CA lung, no survival advantage. But SRS scores over it. But unfortunately, the data with osimertinib, with the TKI and with whole brain RT is not there. Probably in the next year, we will be getting the data. Now, in a nutshell, which is the most effective agent for an EGFR TKI, this AZD3759 is the AstraZeneca where they had only taken for CNS. So osimer better than Afa-Arlo, better than them. What for ALK TKI, lorlatinib scores over all the other things, but lorlatinib has still not been included in the guidelines that I'll be telling. And for a ROS TKI, you have lorla followed by seri followed by crisis. In case of other targetable mutation, probably the data is not. So if I have to say, use drug with the best CNS penetration in patient with CNS mets. $1 million question to everyone. On a Monday morning, if I have a patient with de novo brain mets who are mutant EGFR positive, how do I treat it? So if the patient is symptomatic, give a local therapy, continue with your osimertinib. What about a patient who has taken first or second generation TKI? So you, again, a symptomatic thing, give a local therapy. Now, if the patient progresses in CNS, see for T790M, and even if the T790M, and if it is oligomet also, you change it to osimertinib. This is something different. A first or second generation TKI progression, if you have a T790M, change over to osimertinib rather than giving a local therapy only. If the T790M is negative, change over to SRS, whole brain RT. And then continue with your TKI that I was the previous. What about patient who has a CNS plus systemic progression? T790M positive, osimertinib, T790M negative, give a local therapy and change it to chemotherapy. So these were symptomatic or no symptomatic. What about ALK? So again, if given a chance, symptomatic, add on your local therapy. not symptom alectinib. What about crizotinib failure? So again, if it is not symptomatic, asymptomatic, only CNS meds, oligo SRS. If it is multiple, change it to a second generation. What if it is both progression? Again, change it to LX or brigatinib. And if it is progression after that, again, if it is oligo, give a local therapy, diffuse, go ahead and give your lorlatinib. So what I summarized was, you have a osimertinib, you have a very good first, second, and third generation TKI, but you should never forget your radiotherapy. If it is symptoms, add on your radiotherapy. If asymptomatic, continue with your TKIs and can add on your local therapy if there is a oligoprogression. This is the time to change. Probably the newer drugs has made it possible to change because we are very good and these rajas are nothing but spectacular. I thank you all for a patience.
Thank you, sir. And thank you for that Monday morning thing, which actually happens tomorrow morning. And thank you so much, sir. I would next like to call upon Dr. Rishabh. Sir is a dear colleague of mine and he's practicing at Narayana, Ahmedabad. He will talk about prospective analysis of patients with NSCLC receiving neoadjuvant chemoimmunotherapy prior to resection or definitive radiochemotherapy in routine clinical care, the COMPASS trial. Over to you, Dr. Rishabh.
Hi, I will thank Dr. Nikhil and Dr. Amol for kind invite. Can you please share my slide? So this is an interesting study, hypothesis generating study. It is a prospective analysis of patients with NSCLC who received neoadjuvant chemoimmunotherapy or immunotherapy alone prior to resection or definitive chemoradiotherapy. Next slide, please. So the background or the basis of doing this study was there is feasibility of neoadjuvant chemoimmunotherapy and there were high rates of pathological remission, both major and complete, based on previous phase 1 and phase 2 study. Next slide, please. So in this study, they took 35 patients from 2 centers, of which 12 were oligometastatic, and all patients which were selected were having potentially curative stage, but they were not receiving curative treatment either due to some technical reason like tumor was large enough to give definitive radiotherapy upfront or some functional reason medically unfit patient upfront. So in tumor board, it was decided that these patients would be started on palliative chemoimmunotherapy or immunotherapy alone, and then they will be reviewed after 2 or 3 cycles or 4 cycles with PET-CT or imaging which was done prior, and they will again do tumor board and then decide. So after review of tumor board, patients received either definitive curative treatment or palliative treatment. Next slide, please. So of these 35 patients, 14 patients had PD-L1 of more than 50, 14 had between 1 to 49, and 7 patients were PD-L1 negative. The regimen which patients received, most of them received chemo plus immuno. Only 5 patients received immuno-onco drug alone. So what was the treatment given after the end of neoadjuvant treatment? So 11 patients underwent surgery, which was R0 resection. 2 patients underwent R1 or R2 resection. Chemoradiotherapy was given to 18 patients, and 6 patients could not be taken for curative intent treatment. They received palliative systemic therapy alone. Next slide, please. So the primary endpoint of definitive therapy, whether patient received definitive therapy or not after neoadjuvant treatment, was reached as 29 patients out of 35 could underwent some curative intent treatment, which was 83%. And primary endpoint or assumption was more than 80% would be considered as positive for primary endpoint. Again, according to RECIST, 76% of the patient had either complete or partial response, and there was no new safety signal, and treatment was well tolerated. Next slide, please. So of 27 patients, 7 out of 27 had complete metabolic response. These are the patients who underwent surgery. 6 out of 11 patients who underwent surgery had complete or major pathologic response. Median follow-up at 15 months, patients who underwent curative treatment, recurrence was there in 13 patients, that is 31% of the patients, and death in 3 patients, that is 10% of the patient. while in palliative treatment, 4 out of 6 patients, that is 67% had recurrence, and death 2 out of 6 patients, 33%. Next slide, please. So we can conclude that neoadjuvant chemoimmuno-onco drug is feasible for patients with locally advanced or oligometastatic NSCLC, which for some reasons could not undergo curative intent treatment upfront. And to majority of them, more than 80% of the time, we will be able to give a curative intent treatment. And at the end of 15 months, if 2/3 of the patients are in remission, it seems that of the subset of patients whom we are giving curative treatment, there will be some patients who will receive cure. So cure seems possible in such population, which is really difficult to treat otherwise. I think this is my last slide. Thank you. This was a small poster presented in ELCC. I hope I had just done justice to it.
Thank you, Dr. Rishabh. It was really a nice, insightful talk and probably opens up new avenues to thinking. For our next immuno-oncology section, I have the pleasure to invite Dr. Bowman Dhabar. Sir is a very senior consultant medical oncologist and at Fortis along with other hospitals, and sir will talk on first-line pembro plus chemotherapy for patients with advanced squamous NSCLC. What is a 3-year follow-up from Keynote 407? Over to you, sir.
Thank you very much, Dr. Nikhil. Thank you, Dr. Amol, for giving me this invitation. Today, what I'll be speaking to you on, next slide, first-line pembrolizumab, next slide. We know that phase 3 Keynote 407 study was a study of first-line pembrolizumab plus carboplatinum with taxane. Taxane could be paclitaxel or NAP. NAP paclitaxel was given weekly, whereas paclitaxel was given 3 weekly, versus placebo plus same chemo arm. A protocol specified final analysis, that is at a median follow-up time of 14.3 months, there was a clear improvement in median OS of 17.1 months versus 11.6 months with a hazard ratio of 7.1. So there was a clear-cut difference in the improvement of overall survival and PFS when we use pembro plus platinum plus taxane versus placebo plus chemo in this Keynote 407 trial. Today, what I'll be speaking to you will be a 3 years, that is the long-term follow-up of these patients in the intent to treat population, and what is the outcome of those patients who had completed the 35 cycles of pembro. Next slide. This is a study schema of Keynote 407. This was the pre-eligibility criteria for untreated stage 4 squamous cell carcinoma with a good performance status. You should have a sample, but it was not necessary to have a PD-L1 expression. The provision had to be there for a sample, and asymptomatic brain mets were allowed. This was a direct randomization 1:1 between pembro plus carbo and taxane, pacli or NAP for 4 cycles, followed by pembro as maintenance up to 31. So that comes 35 cycles, 4 cycles here of pembro, and then 31 cycles of this. And in the study arm, this was the study arm, and in the this was the study arm. In this arm, it was a placebo plus carbo plus pacli or NAM, same chemo basically, and placebo was given as a follow-up. This 1:1 randomization was stratified as per the PD-L1 expression, TPS score less than 1 or more than 1, and the choice of taxane, whether it is pacli plus, and the geographic region. The primary endpoint of this study was PFS and overall survival, and the secondary endpoint was overall response rate and duration of response. Next slide. So approximately 560 patients were roughly equally allocated to pembro plus chemo versus placebo plus chemo, and as you can see here, 55%, that is 19.8% of the patients completed 55 cycles of pembrolizumab versus in the placebo it was only 1.4%. Of those 55 patients who completed the 35 cycles of chemo, 7 patients initiated a second response from chemo. As we can see here, in the placebo arm, it was allowed to be on the crossover to pembro. So there was 117 patients crossed over from the placebo arm to single agent pembrolizumab. Approximately 26 patients received some other forms of PD-L1 and were out of study. So there was a crossover of 51.1% from placebo to pembro arm. The median range from time from randomization to cutoff now was 40.1 months, more than 3 years. Next slide. This is the baseline characteristics of the patients who were in the study. And as you can see, most of them were above the age of 65 years. Most of them were males, approximately 80% of males. And even those patients who compared 35 cycles of pembro also, is nearly equivalent. Most of them, 90% were current smokers. Only thing that we find a little difference here is PD-L1 expression more than 1% was around 60% in most of the patients in the trial group, the study group. And in our patients, whom we are going to talk today on those 35 cycles of pembro, those who completed, the PD-L1 expression was slightly high, 74.5%. Next slide. And as we can see, the median overall survival was 17.2 months in the patients who received pembrolizumab versus 11.6 months. And at 3 years, that 36 months, if you can see, the 29.7% of the patients who received pembrolizumab were alive compared to 18.2% who were on the placebo arm. Next slide. As far as the PFS is concerned, we can see the median PFS was again 8.1 versus 5.1 with a hazard ratio of 0.59. And at the data cutoff, not a data cutoff, at 36 months, that is at 3 years, it was the pembro arm did much better than the placebo arm, 16.1 versus 6.5%. So PFS was also better at 3 years, as well as the overall survival when the pembro was used. Now PFS2 was basically from time from randomization to disease progression on second line therapy. And this was also, this is the objective response rates, what we see here. The objective response rates were also, as you can see, in the pembro arm was around more than 60% stable disease, I mean partial response versus complete response. And here also we can see in the placebo arm, it was far inferior than the pembro arm. The progressive disease was 6.1 versus 14.2 in the placebo arm. Duration of response, as expected, was much better in the pembro versus the placebo. Next slide. Now, if we do the overall survival and PFS, and if we stratify as per the PD-L1 status, TPS scored more than 1 versus less than 1. In the pembro plus chemo arm, the median overall survival was 18.7 months versus in the placebo, it was 12.8 months. With a next slide, please. Hello? Previous slide. Hello? Can you hear me? Yeah. So, in my screen, it is not coming. But anyway, and the TPS score, with a TPS score of more than 1, the overall survival was 18.7 months versus in the PDL TPS score less than 1, it was 15 in the pembro. And the basic thing here, what we have to see is that irrespective of TPS, the overall survival and the PFS survival was much better. And even in the 3 years rate follow-up, irrespective of PDL TPS score, it was better. The overall survival and the PFS were better. Next slide. So now we come to those patients who had completed 35 cycles of pembrolizumab. In those patients who had completed 35 cycles of pembrolizumab, approximately 51% of the patient had a response. And if you see here, there were no patients with progressive disease. So out of these 55 patients, 93% of the patients continued to have a good response. The duration of response has not been reached. And 1 year after completion of these 55 cycles, if you can see, 96% of the patient continued to have an improved overall survival, and 82 had a PFS of 82.6% at 1 year after stopping the 35 cycles of chemotherapy. 7 patients who had recurred took the second course of pembrolizumab, of which only 1% was lost. Next slide. See the adverse events here? There were no really major change in the adverse events. If you see, only 1 patient here, as you can see, in the patients who had completed 35 cycles of pembro, had a grade 3 event. Next slide. So to conclude, with a 3 years follow-up, pembrolizumab plus carboplatinum and actually that is the triplet of pembro plus carbo and taxanes continued to show overall and PFS benefit, and this was irrespective of PD-L1 expression. Most of the patients who completed 35 cycles of chemotherapy saw continued to show a good response and good remission. 92.7% continued to be in good remission. Pembrolizumab plus chemotherapy we saw had a good safety profile. Only one patient over a period of 35 cycles had a grade 3 toxicity. So pembro plus carbo versus and pacli is a new standard of care for all first-line treatment of metastatic squamous cell carcinoma, regardless of PD-L1 expression. Thank you very much for your hearing. Sorry for the snag in between.
Thank you so much, sir. Thank you for such an insightful talk. And it really is actually practice changing when we go back to our work tomorrow, where we can think of using pembrolizumab in all squamous NSCLC. Thank you, sir. Over for the next talk, I invite our dear colleague, Dr. Siddharth Turkar. He will talk on the Mermaid 2 trial, which is an ongoing recruiting trial, but a very practice-changing one. And sir is a consultant medical oncologist at Narayana Raipur. Over to you, Dr. Siddharth.
My screen is visible?
Yes, sir.
Okay. The topic of my abstract was phase 3 study of durvalumab in patients with resected stage 2 or 3 NSCLC who become MRD positive after curative intent therapy. Starting with the background, in patients with resected stage 2 or 3 NSCLC, the 5-year disease-free survival rate with standard of care adjuvant chemotherapy is just 40%. Despite advances with immunotherapy in metastatic setting, overall survival rates for patients with recurrence remain low. So before coming to our present study, I would like to revise the 2 previous studies done with durvalumab. So first is a Pacific study. This was a randomized phase 3 double-blind placebo-controlled trial in adult patients with locally advanced unresectable stage 3 NSCLC with more than 2 cycles of platinum-based chemotherapy. The patients were randomized between durvalumab and placebo in 2:1 fashion until disease progression or unacceptable toxicity. The primary endpoint was PFS and secondary endpoint was overall response rate. In this study, we found that the overall survival was better in durvalumab arm. The same was true with progression-free survival and time to distant metastasis. So the consolidation durvalumab improved survival outcome in patients with unresected stage 3 NSCLC without detectable disease progression after curative intent chemoradiotherapy. Again, the second paper which I like to highlight is circulating tumor DNA dynamics predict benefit from consolidation immunotherapy in locally advanced non-small cell lung cancer. This study was published in Nature Cancer in 2020 by Moding et al. So they showed that the freedom from progression 24 months after starting chemoradiotherapy was 0% in patients with detectable circulating DNA compared with 100% in patients with undetectable circulating DNA. The majority of patients in their study consolidation immune checkpoint inhibitor cohort had undetectable circulating DNA after chemoradiotherapy. The outcome of these patients were excellent and the 1 year freedom from progression of 80%. So this is the graph in which it has been shown that those who have detectable circulating DNA has better prognosis as compared to those who have undetectable circulating DNA. Also, they found that in those patients who have not received immune checkpoint inhibitor and doesn't have circulating DNA, those prognosis was as good as those who have received consolidation immune checkpoint inhibitors, showing that the MRD can predict those patients who are going to benefit from immune checkpoint inhibitor. Again, those who have circulating DNA detected post chemoradiotherapy and who have received immune checkpoint inhibitors had better survival as compared to those who have not received consolidation immune checkpoint inhibitors. Also, they shown that those who have circulating DNA decreasing trend with consolidation ICI have better prognosis as compared to those who have non-decreasing circulating DNA. Also, this was true for freedom from distant progression also. They also showed that those who have increasing circulating DNA on consolidation ICI, showing the primary resistance to immunotherapy. So these patients have poor prognosis, same as those who have not received immune checkpoint inhibitors. So the conclusion of this study was that circulating DNA monitoring after chemoradiotherapy and early during consolidation immune checkpoint inhibitor could identify the subset of patients who would mostly benefit from consolidation immune checkpoint inhibitor. Consolidation immune checkpoint inhibitor appears to improve outcome in a subset of patients with MRD following chemoradiotherapy for locally advanced NSCLC. Patients without MRD after CRT appear to have excellent outcome irrespective of consolidation immune checkpoint inhibitor treatment, and rising circulating DNA during consolidation immune checkpoint appears to strongly predict the risk of future disease progression. So on the basis of this study was designed for resected stage 2 or 3 NSCLC who have completed their curative intent therapy and who have been detected MRD positive during surveillance with no disease recurrence visible on imaging. So these patients were randomized in 1:1 fashion between durvalumab and placebo. Durvalumab was given at a dose of 1500 mg IV 4 weekly up to 24 months, and they were followed up until disease progression or unacceptable toxicity. The primary endpoint of this study is disease-free, progression-free survival in patients with PD-L1 tumor expression more than 1%, and the secondary endpoint of this study is disease-free survival in full analysis set, progression-free survival, overall survival, time to subsequent therapy, patient-reported outcomes, and safety. So this is the flow chart. Histologically confirmed EGFR ALK wild type stage 2 or 3 NSCLC who have completed curative intent therapy enrolled in a 96-week surveillance period. They are going to be monitored regularly for MRD emergence via circulating DNA analysis of plasma sample. Those who come MRD positive are going to be randomized between placebo and durvalumab. And these are the primary and secondary endpoint. Thank you.
Thank you, Dr. Siddharth. It was a very insightful presentation wherein you talked about the use of circulating tumor DNA in NSCLC. Usually it has only been an MRD positivity in NSCLC, usually only limited to hematology but a very nice and insightful talk. Thank you, sir. The next talk will be by Dr. Rakesh Pinati. Sir is a senior consultant medical oncologist at Indo-American Cancer Center in Hyderabad, and sir will talk about first-line avelumab in combination with cetuximab and chemotherapy to patients with advanced squamous NSCLC. Over to you, sir.
Yeah, good evening to all. Thank you, Nikhil, for this opportunity. Can someone share my slides, please? Yeah, so I'm going to review this very interesting and short abstract. The presentation is by Dr. Zoran Andrić. The title of the study reads first-line avelumab in combination with cetuximab and chemotherapy in patients with advanced squamous non-small cell lung cancer. Next slide, please. This is a very short study background and scientific rationale of this combination. We all know the avelumab is a fully humanized IgG1 isotype monoclonal antibody directed against PD-L1, which is present on tumor cells. It is unique from other checkpoint inhibitors in that it has a dual mechanism of action. It can inhibit the interaction between PD-L1 on tumor cells and as well as on the and the PD-1 on the T cells, thereby preventing the immune escape, inhibiting the immunosuppression in the tumor microenvironment. The other unique thing about this is that it can activate the NK T cell, it can mediate the antibody-dependent cytotoxicity, and thereby directly targeting the cancer cells. This is because of IgG1 isotype with retained FCR in the avelumab. So this is the two unique mechanisms that avelumab presently has. And avelumab presently is approved as a monotherapy in first-line setting in Merkel cell carcinoma, and in second-line setting as a monotherapy in urothelial carcinomas. And recently, it has approved for renal cell carcinoma in combination with axitinib. So here, the scientific rationale for the combination with cetuximab is that cetuximab also is an IgG1 isotype monoclonal antibody directed against EGFR. And it can also activate a functional crosstalk between the NK T cell and dendritic cells, thereby priming the immune system by recruiting more cytotoxic T cells in the tumor microenvironment. And the hypothesis that it can be more sensitive to immunotherapy. And the combination therapy may also be able to activate both innate and adaptive immune responses by engaging different types of immune cells. As already been explored in the keynote studies, the chemotherapy combination with immunotherapy increases the immunogenic cell death by increasing the tumor infiltrating lymphocytes, CD8 positive T lymphocytes, and NKT cells. Next slide, please. So this is a very short study. This is a phase 2A single-arm multi-center study, basically from the Europe. It was investigating the clinical activity and safety of avelumab in combination with cetuximab, in combination with gemcitabine and cisplatin chemotherapy in advanced non-small cell lung cancer, who are treatment naive in the advanced setting. The key exclusion criteria are that patient with brain metastasis, patient who are having performance status of 2 or more, patients who have taken systemic therapy for the advanced setting, and also patients who have taken immunotherapy at some point of time. The treatment intervention, the study intervention is avelumab, dosed at 800 mg flat dose on day 1, day 8, cetuximab 250 mg meter square on day 1 and 500 mg meter square on day 8, with cisplatin gemcitabine, which is usual dose, gemcitabine at 1250 mg meter square and cisplatin 750 mg meter square. 4 such 3 weekly cycles are given, and at the end of 4 cycles, who are patients who are having a stable disease were delivered with avelumab and cetuximab at 2 weekly as a maintenance therapy until progression or toxicity or withdrawal of the consent. The primary endpoint of the study is best overall response. Secondary endpoint included the safety analysis as well as median PFS and median OS. And also it had several pharmacokinetic and as well as biomarker data. Next slide, please. As I said, it's a very short trial. Around 43 patients were enrolled. At the time of primary analysis, which is July 2nd, 2020, 15 patients, that is 35% of patients are still remaining on study treatment. The confirmed best overall response rates was partial response in 13 patients. There were no complete responses, making the overall response rate of 30%. This is control rate, which includes both the stable disease and partial response, nearly 80%. Median duration of confirmed response was 7.1 months, and event-free survival at 6 months was 61%. So the treatment-related adverse effects, all grade, were present in nearly 90% of patients, and grade 3 was present in 56% of patients, with neutropenia being the most common at 28%. Next slide, please. So fortunately, there were no treatment-related deaths in this trial, and the updated analysis at November 4th, 2020 was showing the median PFS of 6.1 months and overall survival of 10.0 months. We don't have the biomarker data yet. We don't have the updated data, which is yet to be presented. So based upon this analysis, the authors have concluded that the combination of avelumab, cetuximab, cisplatin, and gemcitabine is showing a very good clinical activity and manageable side effect profile. They have not noticed any additional safety signals with the combination of avelumab and cetuximab. So my take on this is it is a very interesting hypothesis. This trial, albeit small, was generating enough data to surely explore this in a phase 3 manner. Surely biomarker data will add more value to decide which subgroup of this small cell advanced non-small cell lung cancers will be benefiting more. And the focus should be from the investigators to add biomarker-based patient selection in the phase 3 trials, and to guide the clinicians to have an extra armamentarium for the management of first-line management of small cell lung cancer, especially squamous cell lung cancer. Thank you.
Thank you so much, sir. A very interesting study and a very nicely presented study, sir. For the next talk, I would invite Dr. Rahul Sood. Sir is a consultant medical oncologist at Command Hospital in Bangalore, and so will talk about the fast progression in high PD-L1 NSCLC treated with pembrolizumab in first line. Is there a prognostic scoring system based on clinical features?
Thank you very much, and good evening to one and all. Thank you to the organizer for giving me a very crazy topic, and luckily while searching for this, I was able to do a lot of lateral reading and probably clear a lot of doubts on those. I've got 7 minutes and I've got only 7 slides, so I'll not take too much of a time, and I'll try to cover like a relay racer for whatever is there. So this was a study which was done in Italy, and like we know, the Italians are very, very passionate regarding the PD-L1 and the immunotherapy. So what they wanted to do is they wanted to find out a prognostic scoring system. And why they wanted to do that is because what they found was that almost 1/4 of their patients in lung cancer who were given monotherapy with pembrolizumab within a period of 12 weeks, that is within 3 months. Next slide, please. So it was a retrospective multi-centric trial which was involving 5 Italian centers, and their primary objective was to investigate the clinical features which were associated with fast progression. That is, individuals who progressed within the first 3 months or 12 weeks in PDL1 who were more than 50%, where we were very, very, very happy that the immunotherapy will work as first line in lung cancer. Next slide, please. So what is fast progression? Once again, anything that progresses within the first 12 weeks, the baseline clinical factors of the patients of these were analyzed and collected, and this was done in a very, very meticulous manner. They involved a lot of statistician in there, and they tried to devise a prognostic score. They studied a total of 321 patients out of the 336. These are the 321 who received first-line monotherapy with pembrolizumab, because all of them had a PDL1 more than 50%. So what happened and what did they find? Next slide, please. So what they found out was that these are few factors which need to be understood. Amongst the 321, they found that 42.7% of the patients were fast progressors. And I do not agree with this data, probably because our Indian population do not progress that fast. But what they found was that the female sex, ECOG performance status 1 or 2, concomitant steroids, I don't know whether it was given because of the corona times, or I don't know why it was given, though it is a no-no. High tumor burden and more than 2 metastatic sites, that is involving the liver, the brain. These were some of the areas where probably the fast progression was seen. So they used these high risk factors to make a prognostic score. Next slide, please. So they used this and they made a scoring system ranging from 0 to 13, something like what we do in probably melanoma or lymphomas. And they found that 0 to 2 were the good prognosis, 3 to 6 was the intermediate prognosis, and then 7 to 13 were poor prognosis. But how did they score it? Next slide, please. So what they did was a 0 point was given for anybody who had an ECOG performance status of 0, male gender, less than 1 metastatic site, no corticosteroids, neither pleural or liver mets. These were given 0 points. Anybody having an ECOG performance status of 1 was given 1 point. 2 point was given for anybody with more than 2 metastatic sites, female gender, use of corticosteroids, pleural mets, liver mets were given 2 points, and anything PS of 2 was given 3 points. On this basis, they found that individuals with 0 to 2 score had a PFS around 15.6%, had a progression-free survival of less than 3 months. That is, they were fast progressors. Whereas a count of 3 to 6, 43.2%. So substantial tripling, almost tripling from the 0 to 2 happened. And individuals with 7 to 13 count had 76.8% progressed within the first 3 months. So probably a validated progression score for the fast progressors. Next slide, please. So what is the conclusion that they brought out? 6 clinical factors were independently associated with fast progression. They found a prognostic score model was developed to risk stratify the potentially improve the clinical practice and selection of first line PDL1 more than 50 in real world settings. So what does this mean in our practice? And I'll take just a minute for the take home message. Do we change our practice on the basis of this study? I feel no, because any individual with a PDL1 more than 50, we will definitely be tempted to give immunotherapy if the patient doesn't have any other driver mutation. Number 2, would we be more vigilant, more careful of all these prognostic markers? Yes, we should. And I think we should definitely keep this in mind, that these individuals are likely to progress. So we need to not keep that on the back of our mind as a pseudo progression after probably 3 months of therapy, and probably keep these markers as probably a cautionary markers for these. Last but not the least, more studies probably on these are required. As of now, I think the immunotherapy probably are the drug of choice for such individuals. However, newer studies are required to make more robust prognostic scores. Probably Indian data is also required. Next slide, please. Thank you very much.
Thank you so much, sir. I would just like to ask, sir, probably in the high risk group, can we add chemotherapy to immunotherapy as well?
Absolutely. I think that is one point we should definitely take home from all this. Though I still re-emphasize that the prognostic panel which is there is not yet vetted or not yet probably standardized and requires still more. But yes, these are few factors where probably we can think of, especially when individual has an ECOG performance status of 0 and 1. Why not introduce chemotherapy in such individual and augment the effects of the immuno and chemo? So I think, yes, that's a very, very important take-home message.
Thank you so much, sir. Thank you for such a succinct talk. And it was really nice hearing from you. For the next presentation, I would invite Dr. Anjana Joel. Ma'am is an assistant professor in CMC Vellore, and she will be talking about atezolizumab as first-line therapy for patients with advanced NSCLC, a systemic review.
Hi, Nikhil. Thank you so much for that introduction. My apologies. There's a problem with my Kaspersky, so my webcam isn't working. You can see my full screen, right?
Yes, ma'am.
All right, sure. So my presentation is actually going to be really brief. So this is something which was presented as an e-poster at the ELCC in March. So this was done by an Indonesian set of researchers, and this looked at this was basically a systematic review looking at the benefit of atezolizumab in the first line for patients with advanced non-small cell lung cancer, especially focusing on overall survival. So when we look at the background and rationale, so this is essentially what they wanted to evaluate. So they wanted to evaluate the efficacy of atezo both as single agent as well as in combination with chemotherapy when you compare it to chemotherapy as the first line therapy for non-small cell lung cancer. So like any systematic review, this is their methodology. So they looked at data from 2015 onwards, and they looked at, so they included studies which were published after 2015. So the procedure, they started it in January 2020. So they searched the traditional databases, and so they found essentially, sorry, one second. Yeah. So they found 11 trials. So among these 11 trials, what you can see is that what I'm going to highlight with the arrows are the 6 trials which looked at single agent atezolizumab in combination with chemotherapy, and the remaining 5 trials actually looked at atezo in combination with either chemo with or without Bev in comparison with chemo plus or minus bevacizumab. Now, any systematic review, when a review is done, you need to ensure quality of the trial. So in this, they use the Newcastle-Ottawa scale, and all 11 studies were actually assessed using the scale, and all were termed as good quality as per the scale. So in terms of how good or how robust the studies were, they were all good quality. Now, when we move on to the results, so this is essentially the top part of this this plot is showing the benefit, the comparison of single agent atezo versus chemotherapy. Now, the second part actually shows atezo plus chemo versus chemotherapy alone. So if you can actually look at the weightage, I'm not sure if you can see my pointer, but if you can actually see the weightage, the atezo chemo combinations actually had a higher weightage, so accounting for 63.5%, and this was around 36.5%. So, and if you look at the hazard ratios for each of these, so when you look at atezo single agent versus chemo, this was around 0.66, and with a confidence interval of 0.54 to 0.81. And when you look at the lower part, which is your atezo chemo combination versus chemo alone, the hazard ratio was 0.75, ranging with a confidence interval of 0.65 to 0.86. Now, how do you grade your evidence in a systematic review? So there is this is the grading of recommendations, assessment and development and evaluation. So the results were moderate. So in terms of significance, so the authors believe that the true effect is probably close to the estimated effect. So it was not high, but it was moderate. So to summarize the results, this was a systematic review of 11 clinical trials, 8,000 odd patients, and with the studies were all of good quality, and the grade of evidence was moderate. And so when you looked at the analysis, there were 6 studies of atezo versus chemo, which showed that there was a trend towards a prolonged overall survival with the hazard ratio of 0.66. And there were 5 studies which looked at chemo plus atezo versus chemo or chemo plus bev. The hazard ratio here was 0.75. Now, this is my last slide. And so this is Monday morning, and take-home messages. There seem to be a trend towards an improved overall survival, either if you use single agent atezo or in terms of chemo plus atezo plus or minus bevacizumab. So that's the end. I'll stop here. Sure.
Thank you, Dr. Anjana. It was so nice hearing from you. And it is definitely a slide which was meant for Monday morning, wherein our practices do get reinforced and changed. Thank you, ma'am, again. For the next session, which is sponsored by BMS, I have the pleasure to invite Dr. Vijay Patil. Sir has been a teacher of mine also, and he is Associate Professor in Department of Medical Oncology at TMH. And sir will be talking about NSCLC disease overview on long-term survival outcomes with nivolumab and metastatic NSCLC.
Thank you, Nikhil. I'll just share my slides. Are the slides visible, Nikhil?
Yes, sir. Yes, sir.
Yeah, thank you, Nikhil, for the invitation. Now, I have a conflict here. The slides are made by BMS Scientific Committee, and honorarium will be paid to Tata Memorial Hospital for me taking this session. So let me continue with the talk, which is long-term survival outcomes with nivolumab in non-small cell cancer. I'm not going to talk about like how lung cancer. This is a very expert audience, and I won't disrespect them by telling about the epidemiology of lung cancer or histology and staging. This is well-known fact. What I would try to focus here is that most of the lung cancers come in as advanced, and the 5-year survival rate, even in developed countries like US, was around 4.3% only. I'm very sure it would be even less in India. And in India, it's not an uncommon tumor. The oral cancers and head and neck cancers are common, but lung cancer is one of the top one. It's right up there amongst first 3 cancers which kill people. And this is a very interesting slide. And the interesting point is that if you see that the median survivals a few years back in lung cancer, I started my oncology career in 2006. At that time, it used to be around 6 to 8 months. At the best, 8 to 10 months. The response rate around about 30%, around 1/3 of your patient would respond. And most of the people would die. You would hardly see less than 10% going beyond 2 years, and hardly any patient going around 5 years. In fact, at that time, a survey was taken in Canada, and Canadian medical oncologists were asked that if they had lung cancer, would they themselves take second-line treatment or not? Interestingly, only 5% of medical oncologists in Canada actually agreed to take treatment if they themselves had lung cancer. One of the reasons which were given was that they thought that the efficacy of chemotherapy in second-line treatment was very less, and the toxicities was high. When the survey was repeated with respect to asking them in first-line treatment whether you would take the take treatment or not, this number went up to 20%. So you could see that there was quite a bit of nihilistic attitude, even in medical oncologists in developed countries, regarding treatment of non-small cell lung cancer. And the survey was done in 2005 and 6. At that time, we didn't have much knowledge about or targets of driver mutation were not available. So what was there at that time? It was mainly docetaxel, which was used to be used as a second-line treatment options. And we all know that even in first line, or when we give it in breast cancer or in head and neck cancer, docetaxel is a tough drug. Quite a few patients have side effects, myelosuppression being common, diarrhea being common, and we need to give prophylactic GCSF to quite a few of our patients. These are well-known facts which you consider when you are treating a metastatic non-small cell lung cancer. According to me, performance status is most important of them. Performance is 3 or 4 definitely doesn't benefit from therapy. And whenever you're looking at second line treatment, what responses you got with the first line and toxicities what there were with the first line are also important to look. It's important to discuss with the patients the benefits, the toxicities of the treatment, and take into consideration even what the patient preferences are, because that, according to me, is an important factor. What the patient wants from the therapy, and and sending the patient for early palliative care, according to me, is an important aspect in treatment of non-small cell lung cancer. Now, what does the current evidence suggest? The current evidence suggests that if the patient is PS3 or 4, then he goes for best supportive care only. If it is less than PS less than 2, you give systemic therapy. These are the choices which NCCN recommends. When progression, these are the choices which would be recommended. Similar is the flow if you even had a squamous cell carcinoma, except that you could see that bevacizumab is not there, which we know that it's active mainly in adenocarcinoma. What I'm going to tell you is that in second line therapy, a decade back, there used to be a very nihilistic approach that less than 1% by 1 year, 2 years, less than 5% of patients used to be alive. What changed is this CheckMate 2 trials 17 and 057, which looked at comparing nivolumab to docetaxel, nivolumab single agent in previously treated non-small cell lung cancer. What we have now is a 6-year overall survival rate. And what it shows is that even at 6 years, nearly 14% of your patients would be alive. Now, some of you may think, oh, what great is that? Understand these were stage 4 lung cancers and these were in second line and beyond setting. The data at that time suggested that very few of them were supposed to be alive after 2 years, which here were nearly 1/4. And quite a few of them continued up till 6th year, and there's still some which are continuing beyond that. This was like unheard of on Earth. To give a comparison, if you look at pancreatic cancer, we do Whipple surgery, which is a very big procedure. The stage 1 Whipple cancers, median overall survival is only 14 to 16 months. When you do it for stage 2 and stage 3, the 5-year survivals are in the range of around 10 to 20%. Similarly, with locally advanced esophagus, especially squamous, the 5-year survivals are similar range in India. So what we are looking at is this is a very respectable number with respect to when you compare it with even with respect to certain curative tumors in which we require extensive surgeries, especially when this is coming in second line or beyond setting. Now let's look at this data, slightly more careful. CheckMate 17 actually dealt with squamous non-small cell lung cancer, and 57 dealt with non-squamous non-small cell lung cancer, and there was 1:1 randomization. Nivolumab, the dose used was 3 mg per kg here, and docetaxel 75 mg per meter square. Overall survival was the primary endpoint. What we see here is, when you look at the pool data, is that here the curves nearly are similar for the first 6 months, but after that they start separating, and they keep separating. And this is what I was talking to you, that when you used to treat with docetaxel, around 10% of the patients only used to reach up to 2 years, which is now 1/4. And these patients, quite a few of them, around 10 to 15%, do go up till 5 years. Now, the question comes is, what if the patients, now the recommendation, the label is to give it for any second line patients, but if the patient has a PD-L1 score of greater than 1%, the question comes, how many percentage of the patients have that score? In normal, it's said that more than 50% is seen in 1/3 of the patients, and 1 to 50% is seen in another 1/3 of the patients. So you're talking about nearly 2/3 of your patients if it's adenocarcinomas, and nearly around 30 to 40% of your patients if it's squamous cell carcinomas. And what it shows is, if the PD-L1 is high, these numbers are even better. They are nearly 1/3 of your patients would be alive at 2 years if they receive nivolumab, and nearly 20% of their patients would be alive at 5 years if they receive nivolumab. What if the score is less than 1%? Is there no hope for those patients? No. The results are not promising, but still you would get reasonable around 10% of patients who are going up to 5 years, which again suggests that PD-L1 alone may not be the best marker in this patient. The similar findings were seen with the squamous cell carcinoma patients also, where you had around 10 to 15% of patients who would go up till 5 years. Now, what you can see in this graph is that the benefit is there irrespective of the histology. The benefit is definitely more if the patient has a higher PD-L1 score, but it's also there if the patient's PD-L1 score is less than 1%. It's higher if your ECOG performance status is better. But now the question comes is, if you have a response, we know that around 15 to 20% of your patients would have a response. Do the patients who have response, they do better? And yes, those patients who have response, yes, they do better. Just look at this graph. This graph is for patients who responded. This is with docetaxel who responded, and this is with nivolumab who responded. You could see that the duration of response is very slow with docetaxel. So you would have a PR, but this PR will get lost in most of your patients within 5 to 6 months. As opposed to that, if you have a CR or PR with nivolumab, this PR is sustained for a pretty long time. And it's interesting that those who respond, nearly 30% of them are alive for 5 years or beyond. That's a very high number. And if you see, the 2-year survival is nearly 50% for those who respond. So again, it's suggesting that those patients who respond to immunotherapy, they do much better than patients who don't respond. And even if patients respond to chemotherapy, that doesn't mean that they're going to do better for a long time. The duration of response with chemotherapy is on the lower side. Now, one of the things which we always say is that, okay, if patients have gone beyond 2 years, even with docetaxel, would they still do better or not? So we would say that patients who do better up to 2 years, they're as such biologically good patients, and they as such would have done better. To test this hypothesis, a landmark analysis was done in which they selected patients who had done were 2-year progression free. And what it showed is patients who were 2-year progression free in the docetaxel arm, none of these patients were actually alive by 5 years, while the same proportion for patients who received nivolumab was nearly 60%. Those patients who were progression free for 3 years, the probability of them being alive at 5 years is nearly 93%, which again suggests that patients who respond to nivolumab, the duration of response is sustained for a far longer time than its chemotherapy. Now, what are the factors? This column, I'm more interested in this columns here, where they are compared patients who had failed within 1 year to patients who had gone beyond 5 years. What are the factors? So, like if you're in a OPD setting, which are the patients which are likely to do better and would like to be surviving for 5 years or beyond? It seems that patients who have a good performance status, they do better with nivolumab. And it is practical also. Patients who have a lot of symptoms, lot of low PS, they don't do better with immunotherapy drugs. Immunotherapy drugs take some time to act, and then that action is sustained. Obviously, patients who have a higher PD-L1 do better. So these are the two patient populations which are good PA performance status and a higher PD-L1 expressions are the patients who do better. Whether they have CNS mets, whether they have liver mets, it actually didn't turn out to be of any practical significance. The question also comes as those who patients survived for 5 years, what kind of treatment they received? And this is another thing which we have seen in India. Normally in trials, what happens is if you first line is received by 100 patients, the second line is received by 60 to 70% of patients, and third line is received by 20 to 30% of patients only. Now, when you give immunotherapy, the probability of uptake of further treatments also increases, which you can see well in this graph, that further treatments were received by these patients, and probably they also contributed to the impact. It has been said that, for example, if you have if you give immunotherapy in second line, and that would be your PFS2, that was the PFS or immunotherapy. The PFS which you get after you are given immunotherapy, that is the PFS3, is quite frequently better than the PFS1. Which means what progression-free survival you received with the first line. If you give immunotherapy in the second line and you give a third line agent, the progression-free survivals are frequently better than what you would have, what in that patient would have achieved with the first line of therapy. The dosage, it's don't have to repeat it. It's 3 milligram per kg. You can also do 240 mg as a flat dose. The question comes if the patient takes these drugs for a longer time, do they have adverse events? No, actually, no. So these were the kind of adverse events. So you see that grade 3 of 1, this percentage is only 3%, which means that yes, if the patients tolerated better, if initial time you may require dose reductions, but after that they actually do better. And the commonest side effects which can happen as any grade events is commonly diarrhea, which can be seen, but more or less these are manageable side effects which are there with nivolumab. So what I would say is that nivolumab, if your patient has not received an immunotherapy in the first line setting, seems to be a good option for the treatment. You could get 5-year oral survival in these patients, which is seen around 10 to 15% of the patients. Figures are high if the patient performance status is 0 or patient's PD-L1 score is high. And late onset side effects are not much. With that, I would say thank you. If there are any questions, I'll take. Thank you to the organizers, and it's over to the organizers.
Thank you so much, sir. Thank you for such a wonderful, insightful talk. If there are any questions for sir, I think you can put it now, or we can put it in the question answer session. If there are no further questions for the next talk, I would ask Dr. Ashish Joshi to join us. It is a session sponsored by Roche, and sir will be talking about atezolizumab monotherapy in second-line management of metastatic NSCLC. What are the recent updates? Sir is a consultant medical oncologist at Mumbai Oncocare Center, and sir actually heads that team. So over to you, sir.
Thank you, Nikhil. Thank you for that kind introduction. Thank you, Amol and Nikhil, for giving me this opportunity. I also thank Roche for giving me the scientific platform and the information, which I intend to share with you in next few minutes or so, and that remains my conflict of interest. I will share my screen. Is the screen visible for everyone?
No, sir, unfortunately.
Sorry. Is it visible now?
Yes.
Yeah. So I think all of us have subsumed with the fact that second line treatment for a non-small cell lung carcinoma is a realistic situation that we all see in our clinical practice. So I would certainly not belabor the data because Dr. Vijay has already expounded that quite extensively, and that almost close to 50 to 60% of our patients whom we are going to see on Monday morning are actually going to be in for a second line treatment for this very difficult to treat disease few decades back. We would be probably discussing a second line option maybe a couple of years down the line when a lot of our patients actually would be receiving first line immunotherapy, and that's where the crux of the situation would lie. But currently also the challenges are plenty, and hence we are discussing this particular concept very extensively as a part of the ELCC update.
Hello.
So just to put all the colleagues, esteemed colleagues here on a common platform, that docetaxel remains the standard of care. The switch maintenance of erlotinib is being discontinued and is no more FDA approved, and hence possibly those patients who have received first line therapy with platinum based doublet would end up receiving docetaxel as a second line therapy. You also have an option of adding ramucirumab as a second line treatment options. We also have an option of vinorelbine and gemcitabine, but docetaxel has been found to be superior to all the other agents which have been there as far as the second line therapeutic armamentarium is concerned. Then 2016 and 17, we had 3 important FDA approvals, all for immunotherapy agent irrespective of the PDL status except for pembrolizumab, which needed PDL1 of more than 1% even in the second line setting to have been used as the therapeutic treatment options for second line treatment, both for squamous as well as non-squamous histology. So in essence, we have 3 options. We have Keytruda, we have nivolumab, and we have atezolizumab as one of the 3 treatment options for second line therapy of advanced non-small cell lung carcinoma both squamous and non-squamous histology. All the three treatments have been FDA approved, and all of them have shown to prove an overall survival compared with docetaxel. What we need to deeply understand here is to which one do we choose from? Is there a choice of one over the other in a specific subgroup of population that we see? And do we have any specific adverse event profile to be discussed? So I will be splitting my talk into three important parts. First, of course, is the OAK trial, which is the phase 3 trial, which actually got an approval for atezolizumab in the second-line treatment of non-small cell lung carcinoma. I would then dwell on to a very small study for a real-world scenario, which involved a diffuse population, which is typically not included in the clinical trial, but very proximally and viscerally seen in our clinical practice. And lastly, I would just have a very quick snapshot of a cross-trial events, obviously knowing the limitations of the so. But this is very important because we have got three choices at our disposal for the treatment of second-line treatment of an advanced non-small cell lung carcinoma. So as you all are well aware, a very important landmark study which was published in Lancet, which involved locally advanced or metastatic non-small cell lung carcinoma. It included both squamous and non-squamous histology. It included patients irrespective of PD-L1 status. Interestingly, it also included treated asymptomatic CNS metastasis patient, and it had a patient pool of approximately around 1,200, but analysis of 850 was good enough considering the intent to treat population primary endpoints which were reached with the events that occurred in this group of patients. The stratification factors again were PD-L1 expression histology, prior chemotherapy regimen. The randomization was 1:1, and the patients were randomized to conventional dosing of atezolizumab at 1,200 milligram every 3 weekly versus docetaxel till the disease progression or a loss of clinical benefit. And the primary endpoint were overall survival in the intent to treat population, overall survival in a specific group of patients which had PD-L1 expression more than 1%, and obviously the secondary endpoint were overall response rate, progression-free survival, disease control, and safety. So let me just head on to the important Kaplan-Meier curve, which puts all these patients together in a group. And this is a telltale sign that you have got a hazard ratio of 0.73 across subgroup with a minimum follow-up of 19 months, which showed here that patients who were in atezolizumab group had a significantly more median overall survival compared with docetaxel, 13.8 months versus 9.6 months. And there is a very early separation of curve, very interestingly, because typically we see a delayed responses with immunotherapy, but here you are having fairly good response early into the event. So around 9 months, if you look at that, the curves have started conspicuously separating and being quite deep and dawningly different at around 12 to 15 months. So again, statistically significant p-value, you have hazard ratio of 0.73 in a patient across the subgroup. Now OS was further improved when Tecentriq was used in a patients with a very high PD-L1 expression level. As you could see in this forest plot, those patients who had a high TC3 or IC3 score, which reflects higher PD-L1 expression, they naturally and very, very logically did better than patients who did not have PD-L1 expression. Having said so, even those patients who did not have PD-L1 expression, the hazard ratio was 0.75, favoring the use of immunotherapy irrespective of the PD-L1 status as far as the atezolizumab is concerned. Again, coming back to the OAKS trial, provides us a superior 2-year overall survival benefit versus docetaxel in the intent to treat population. As you could see here, 55% versus 40% 1-year OS and 31% versus 21% 2-year OS. And as we typically see a tail of tail, that the benefits have continually lingered in a patients who have received immunotherapy, and you have seen a fairly good long-term survivors even in the second-line setting when treated with immunotherapy. These are the median duration of response, which I alluded to in the previous slide of mine. This particular bar chart again reiterates, exemplifies, and amplifies the similar concept that in an intent to treat population, you have got a deeper and a longer response. And those patients who had a good PD-L1 expression actually had an even better response when treated with atezolizumab versus docetaxel. And the difference is quite big, 6.2 versus 16 months. These are the typical X-ray CT scans that we see, and I think that is quite not nuanced to our clinician friends here. So I would skip that and would not belabor it here. Now let's look at some of the important intent to treat population and the subgroup analysis. Even in the patients which had KRAS mutant, which are typically resistant to most of the therapy, you had actually a response rates with immunotherapy. And the problem areas, of course, and that's where we are not doing good as far as the second line treatment is concerned, that those patients which were EGFR mutant and were put on to second line immunotherapy, they did not do well. And possibly that is the area wherein we have a better second line TKIs like osimertinib, or probably we need to look at augmenting the treatment more than just monotherapy with atezolizumab. So again, very, very important point to note here. And in this, probably you could see across all the second line IO trials that those patients which are EGFR mutant actually do not do well with a monotherapy in a patients with advanced non-small cell lung carcinoma who has progressed on first line TKI. Again, a very characteristic that the patients which were smokers actually do benefit, but even here the responses were seen even in non-smokers. The patients who had CNS metastasis also had a good disease control, and this is a very important clinical dogma or a conundrum that we face in our clinical practice routinely. And the patients who actually were elderly, and this is again a very common subgroup that we see today, also did benefit with a hazard ratio favoring atezolizumab versus docetaxel. So when you treat patients with cancer immunotherapy in your clinical practice, these are the typical questions that we ask. How long do we continue with the treatment, and what happens beyond disease progression? And that is where a very important clinical scenario which commonly arises, that you put the patient on an IO regimen, and at the end of 4 cycles or a presumed number of cycles, you do a scan and you actually see some amount of radiological progression, but you have actually seen a lot of clinical benefits. And then what do we do? So this particular trial, as I had mentioned before, actually continued to use immunotherapy provided there was a clinical benefit as per the investigator. There was no signs and symptoms indicating unequivocal disease progression. There was no decline in performance status attributed to disease progression. There was no tumor growth at clinical sites, and patients with approved alternative therapies acknowledged deferring these therapies via ICF. So this is actually a common clinical scenario that we see, that there is some disease progression or oligoprogression. Patients are actually clinically benefited and you are reluctant to change the treatment. But what do we do in this clinical practice? So this trial beautifully end up studying these aspects of the treatment as well. And if you could see here that those patients who had actually a progression on the RECIST 1.1 criteria actually did benefit by continuation of immunotherapy in terms of partial response rates of 7.1% and even a disease stabilization upwards of 40%. So which is pretty impressive in this group of patients which are actually progressing on the RECIST criteria but clinically benefiting. And hence we probably have some evidence here that we could continue to use on to IO or hold on to the important midfielder oncology drug here in the second line setting, and probably continue to derive the benefit with at least disease stabilization or a partial responses. This particular Kaplan-Meier again reiterates the same fact that this is where actually the event of progression happened. But if you continue to use this drug beyond that, then you actually having 18 months OS in almost 37% of the patients who have actually progressed by RECIST. And if you compare that with the docetaxel arm, then the responses are quite dismal. Again highlighting then possibly this could be one of the way of going ahead in managing the patient in our clinics. Overall survival curve again stays separated post PD despite patients who have actually had progressed in terms of RECIST criteria. As you could see here, that the difference between the two curves is still yawning, and the difference continues to remain separated as we go down the line and we have the mature data of this particular study. So in 2020 ISMO, there was a 4-year overall survival update. Mind you, this is POPCAR was a phase 2 study studying atezolizumab monotherapy in a patients with metastatic advanced non-small cell lung carcinoma who has progressed on first line therapy. Again, a very impressive hazard rate of 0.76 with a statistically significant p-value. And the OAK trial, which I alluded to in last few of my slides, again reiterates the same fact that the patient continue to derive benefits even in long term, and you've got a significantly impactful hazard ratio of 0.78 with a statistically significant p-value as a long-term analysis of this particular study. If you could want to belabor it further and dissect it further, then both particular population, both non-squamous, very interestingly, actually derived the benefit with atezolizumab compared with docetaxel, both in Poplar as well as the OAK study, and even squamous cell patients ended up deriving the benefit with this particular regimen. It's no brainer that the patients who had a high PD-L1 score actually derived benefit, but the patients who did not have PD-L1 expression as well did benefited with the inclusion of atezolizumab as a monotherapy in the treatment of advanced non-small cell lung carcinoma. This particular Kaplan-Meier curves again reiterate the same fact that irrespective of the PD-L1 status, you do get benefit, but those patients who have more PD-L1 expression continue to derive better benefits with patients with atezolizumab. So Poplar and OAK trial, this is just a summary of where we are. The median duration of the response, as is always been an attractive point for immunotherapy, is very deep and long, 26.5 months versus 6.2. And that is something which is very, very attractive, that the patients who continue to respond to immunotherapy do derive benefits even with the long-term and deep impact as far as the continuation of the treatment regimen is concerned. And again, the subgroup analysis has been exemplified here, that those patients who had higher PD-L1 score, those patients who continued beyond progression actually did benefit if they were actually getting clinically benefited and had consented for continuing with being on atezolizumab as a monotherapy. So again, I would not like to reiterate, this is again the similar control that possibly highlights the importance of this particular data of a four-year long-term data of OAK study, which reiterates the important disease control measures that we have. Now, this is an important slide which I would just like to allude to, that important adverse events, that when you're talking about second-line treatment, you're already concerned about toxicity. There were some grade 3, grade 4 event of any cause, but treatment-related grade 3 and grade 4 adverse events were very minimal, and there was no treatment-related death or interruption in patients who were on atezolizumab monotherapy versus patients who had docetaxel. So some of the important conclusions is that a long-term follow-up of the randomized Poplar and OAK trials with a 4-year data now suggests that consistently increased survival benefit with atezolizumab versus docetaxel in previously treated patients for advanced non-small cell lung carcinoma, irrespective of the PD-L1 expression. The majority of the docetaxel arm 4-year survivor actually ended up receiving PD-L1 monoclonal antibody immunotherapy as a subsequent anti-cancer treatment. Radiographic response is not a requirement for a long-term survival, as some of the patients continue to derive benefits even they have technically progressed by the RECIST criteria, and atezolizumab showed a consistent and manageable safety profile with no grade 4 and grade 5 adverse event. I would just go on to give you a glimpse of what this TAIL study was. This was basically a global single-arm study of atezolizumab monotherapy in diverse population. And just to highlight what are those diverse population, those patients who had performance status 2, those patients had a severe renal impairment, those patients have some amount of autoimmune disease, those patients who have active or chronic hepatitis B and C viral infections, those patients who had untreated asymptomatic CNS metastasis, actually a typical real world scenario patients that we see, though obviously it's not a phase 3 clinical trial, but they did continue to derive benefits, especially the patients who had a poor performance status, especially those patients who had got a severe renal failure, and even those patients who had a mild to moderate autoimmune dysfunctions continue to derive benefit. And of course, large number of patients also had OAK-like population, typical clinical trial population that we see, and they actually continue to derive benefit with the inclusion of atezolizumab. Again, reiterating the fact that important real-world evidence that a diverse group of patients could actually get benefited with inclusion of atezolizumab as a monotherapy. Again, summary of primary analysis, it's confirmed that safety profile of atezolizumab monotherapy is diverse in a previously treated non-small cell lung carcinoma population. Just to conclude my talk, as I had mentioned before, that cross-trial comparisons are hazardous, but here we have CheckMate 017, nivolumab versus docetaxel, CheckMate 057, nivolumab with docetaxel in non-squamous, Keynote 010, pembrolizumab in squamous and non-squamous only with PD-L1 expression of more than 1%, And then we have the OAK study with squamous and non-squamous irrespective of PD-L1 expression. Though obviously cross-trial comparisons are hazardous, this is the data that we have. All of them actually showing a improved response rates, improved overall survival, and we are actually spoiled by the choices. But if you could just sort of tease some of the important characteristic here is that probably you have got a little better data of atezolizumab in a patients which are non-squamous population. You slightly have improved data in a patient who has got a PD-L1 expression even at a lower level. And if you could see here is that this particular chart that squamous and non-squamous 12.6 versus 8.9 months in a patients who have actually no PD-L1 expression continue to derive benefits with patients when treated with monotherapy. So I think we have multiple choices here now in our therapeutic armamentarium. These are the NCCN guidelines, as we have mentioned here, that nivolumab, pembrolizumab, and atezolizumab, all three have been approved for the treatment of metastatic non-squamous as well as squamous non-small cell lung carcinoma who has progressed on first-line therapy, and they continue to derive overall survival benefit with this particular group of therapies that we have. I thank you all for this patient hearing and would be happy to take any questions, if any. Thank you so much.
Thank you so much, sir, for such an insightful talk. And it was quite comprehensive in the way you even included the TAIL study, as in it was one of the studies which actually offers the real world scenario where you might want to use immunotherapy for a variety of reasons where chemotherapy cannot be given. Thank you, sir. If
Thank you so much.
Anybody has any questions, please drop it in the question answer session or put it in the chat box. For the last session of the day, I would again request Dr. Amit Ratan. Sir is a consultant medical oncologist at Manipal Hospital, Bangalore, to be the moderator for the session. Sir, are you on board?
Yeah, Dr. Nikhil.
So
Right.
the panelist, we have an eminent list of panelists, and for the panelist, I would invite Dr. Kushal Patel. Sir is a senior consultant medical oncologist at Metas Adventist Hospital and Elite Hemato-Onco Care Center in Surat. Dr. Uma Dangi, ma'am is a senior consultant medical oncologist at Fortis, Mumbai. Dr. Amol Patel, sir is a senior consultant medical oncologist at INH Ashwini. Anup Toshnawal, sir is a consultant medical oncologist at Max Care Clinic, Aurangabad. Dr. Rajiv Seni, sir is a medical director and senior consultant medical oncology at Sri Mata Vaishno Devi Narayana Super Specialty Hospital in Jammu. Over to you, Dr. Amit.
Thank you, Dr. Nikhil. Thank you again. Good evening, everyone. So what we will do is in the next 30 minutes, quickly talk about extensive stage small cell lung cancer and how we go about managing it. So just to put in a background, we'll just take a quick case so that then we can all start discussing about it. So here's a 54-year-old smoker who's presented with cough, hemoptysis, weight loss. Scan is showing that right lung mass, central hilar mass, mediastinal nodes, liver metastasis, stage 4 disease, and the biopsy shows that we get a small cell lung cancer from the biopsy. So here, let's start with this. Let me start off, Dr. Kushal Patel. What do you do nowadays in small cell lung cancer after you get the histopathology? Are you anytime thinking of any biomarkers, even anytime in practice?
Hi, good evening to everybody. Not in small cell lung cancer. Frankly speaking, I am not going for any biomarker in this case, neither PD-L1 nor tumor mutation burden.
Right. So that's how it is based on in small cell. But what do you think would be the role of TMB if you think in small cell? What are your thoughts about it?
From treatment's point of view, I don't think so. It has much important roles to be played. But from predictive point of view, we can have some idea during our treatments protocol. We can have some immune therapy drugs to be combined with the ongoing or start to be chemotherapy drugs. That is some point of view backup with PD-L1 and TMB to get some positive response with immune therapy if we add with the some chemotherapy drugs. But technically speaking, in small cell lung cancer, the utility of these two markers are not so much extensive as in other malignancy.
Absolutely, you're absolutely correct there. So I just wanted to bring out this point. It is a very interesting point. In small cell lung cancer, these are all smokers, and they have high mutations, and they always are the ones you would kind of think they should have high mutational burden and they should respond to immunotherapy. So this is always quite a controversial thing. It should ideally be the best ones for immunotherapy, but unfortunately we get limited response. We do get response, but we don't get the kind we would have thought with high tumor mutation burden load. And surprisingly, PD-L1 always is very less in small cells. Again, that's the TPS. If you do PD-L1 by the TPS, you will really get a very low TPS in small cells. So I agree with Dr. Kushal. There's absolutely no role of doing any kind of a biomarker testing in small cell lung cancer. So Dr. Uma, I will ask you, so if this patient comes to you, what are your first line choices for this management? So I'm just putting it in terms of chemo, and if it is chemo, platin etoposide, carboplatin etoposide, or chemo immuno. So what are your thoughts in this?
So in today's day and age, obviously with the recent updates and recent trials, we know that immune checkpoint inhibitor added to a platinum etoposide combination does improve overall survival. So definitely that would be my first choice of treatment, and obviously followed by putting them on maintenance immunotherapy. The choice of platinum would basically depend upon the fitness of the patient, whether it can tolerate cisplatin, if too elderly, poor EF, or go for carbo. But platinum with etoposide and IO would be the first choice.
Right. So you're not really insistent on cisplatin, right? You're okay with carbo, eto, and
my first choice is usually cisplatin. I'll be honest, but sometimes because of comorbidities and other stuff, if I feel kidney function, etc., then I switch to carbo. But otherwise, first choice is always cisplatin for me.
Right. Okay. So platin etoposide with IO, I think all of us will kind of say, if we have a best of the situations, that's the best way forward, and that's how we would try to look at. So no one talks about reserving IO for the second line, right? Dr. Amol Patel, any time you would think in small cells that you want to reserve the IO and not bother about it? Dr. Amol Patel?
Dr. Amol Patel, sir, and Rajiv, sir, is not there.
Right. Okay, thank you, thanks. So Dr. Anup, well, I would take your inputs on this. Are you clearly emphasizing on IO to be pushed into the first line if you're using it in small cell and no other lines?
Sir, I would personally prefer to give it upfront because the overall survival is very less, and I will not like to miss a chance to hit it hard and hit it early. Second thing is regarding the choice of cisplatin and carboplatin, sometimes they have SIDH. Patient are sometimes very sick. So there I would prefer carboplatin if patient has SIDH, because cisplatin hydration becomes an issue. Other than that, it totally depends upon the toxicity profile of cisplatin versus carboplatin for choosing the partner in that.
Right.
I will try to give in the first line only immunotherapy, hit it early, hard and fast.
Right. So clearly IO first line, not many patients will get to second line. We know it, and we really don't want to keep a reservation of the immunotherapy if we are going to use it. I don't know. I kind of think using this platin debates, still it's such a sad thing that we still hear the same thing. For 20 years back, we used to talk the same thing, carbosis. But I personally think it doesn't matter. Whichever platin you're comfortable with and you think your patient can tolerate, it's perfectly good. I'm not really very insistent on which platin. You should be comfortable and your patient should be comfortable. So now we come to the choice of IO, and so let me come to Dr. Nikhil. What is your thoughts about the choice of immuno? Now you have both these approved. You have Atezo and you have Durva. Both are approved with platin etoposide. What do you do, and how do you think about it?
Sir, I would like to answer a question with a question that are there brain meds in?
Okay, that's a good one. So I will, let's start off with no brain meds in this. Later we'll talk to that brain meds. Let's put this as no brain meds.
So then, see, I know the session is sponsored by somebody, but I have more usage. I have used more Atezoli with carbo and etopo, and this is what I have been using. And As regards to carbo and cisplatin, I think the debate can go on and on and on. But for me, it would be atezolizumab with carboplatin and etoposide. But to be really fair, durvalumab does offer some advantage, especially in consideration to brain mets, especially in terms of the dosing. So later on, durvalumab goes to once a month dosing, and it is very convenient if we have a once a month dosing with durvalumab.
Right, right. So I think you're perfectly right there, because atezo came in first and got approved first, and durva got approved next when this Caspian data came up. All of us had started getting some hang on using atezo, and now we are getting hang on how to using durva. So the whole decision will come on. Both the IOs are fully approved, and we'll probably need to just look at how are we going to choose it for our patients. So just to put the facts of the Caspian study, a very large phase 3 study, platin etoposide in comparison to platin eto with durva, and of course there was the third arm which was stopped because adding the CTLA4 did not show any benefit. So there are a few points about this study, and there are a few differences. But before we come to that, the primary endpoint of looking at overall survival, it was significant, 10.5 months versus 12.9 months, hazards of 0.75, clearly significant. And this last year we saw a follow-up data, and that's the first time we are seeing 2 years data, and you're seeing 22.2%. So you're talking of 22% patients being alive at 2 years versus 14% with chemo. So clearly there are patients who are getting to the small tail of the curve, which is showing that there is extended survival. So again, Dr. Kushal, what are your thoughts on these data sets? Are you kind of impressed with it? I hear both ways, you know, I don't deny this. And whenever we talk of immuno in small cells, we have this lot of conversation saying that it's only 2 months. And sometimes we say it's very less compared to, we would have liked to see what we see in non-small cells or in other cancers. So there's always that thought in the mind. What are your thoughts about this?
Absolutely. As we know, we all know that the small cell malignancy is not so good malignancy. It's a little aggressive malignancy. So in that particular subset of the patients, if we get 2 months of the advantage with quality of the life, then it's not bad actually. And from this graph, we can say that approximately 22% of the patients, they can reach up to 2 years also. So it is quite reasonably good if we make a stage 4 or extensive stage small cell lung malignancy to survive beyond or at 2 years. So it is not bad. If the patient's affordability is not an issue, then we can definitely add any of the IO along with the chemo combination therapy.
Right. So I think you make a good point of that 2 years thing, is that we are talking of, we are trying to get them to longer date. That's the main thing, longer survival with quality of life. Dr. Uma, your thoughts on this? Are you happy with this data sets, or what are your thoughts?
I mean, it's a start, I would say, in small cell lung cancer, where we did not have anything for so many years, and we were just playing with platinum and etoposide for so long. So I think it's a small step, but it probably it's not the best, but it's hopefully we will get there. But definitely, for 2 year survival of 22% in small cell lung cancer with first line of therapy, really, it's really. What do you call it? It promises some kind of hope for these patients. So yeah, I'm okay with this. Yes.
Right. So that's the thing. It's as you mentioned, very well said. It is a start, and we would like to get better and better. But we are clearly having a positive trial with some improvement. The reason is we should not really look at medians alone. Just if you look at medians, you'll only look at that 2.5 months. But we should look at time frames, and it's important to look at the 1 year, the 2 year, and probably I'm hoping the next year we'll see 3 year data sets where we see longer patients getting on the tail of the curve. So this is what Dr. Nikhil mentioned to us, that there are varying points about the Caspian design. So the one was, it allowed flexibility of using cisplatin versus carboplatin, which was not there in the atezo trial. They used only carboplatin. The second was the comparator arm got 6 cycles of platin-eto. And so that's one thing more, is something like what we would prefer, and we do in real world. We don't like to stop off at 4 in small cells because there's nothing more to offer. So we give them 6 cycles, and that's what we prefer. And also PCI was So another thing was the brain mets, which Dr. Nikhil mentioned. Brain mets were treated and stable brain mets were included, and also if they were asymptomatic and untreated were also there. There was a small number of asymptomatic patients also included, but in the Atezo trial you didn't have that part of it included. So PCI was also optional, was offered in the control arm as maintenance. So what we are seeing here is the standard of comparator arm is getting the best of care. You're getting 6 cycles, you're getting PCI, you're getting the best of treatments you can, and you're still having an advantage. And that's probably where Caspian has slight difference with Atezo arms. So these were the differences which we kind of talk about. So again, Dr. Anup, your thoughts on this, the flexibility, would it really matter? And the number of cycles, would it really matter? Or the brain mets, that's what matters?
So the flexibility is definitely an advantage because you have on paper data where you can where the patients were including with the brain mets. So I will be more confident in giving durvalumab when you don't have the data for itolizumab. And platinum etoposide 4 to 6 cycles is fair enough. If patient is not tolerating, I stop at 4. If patient is tolerating well, no major toxicity, and there is a good benefit, I continue up to 6. So that is not very relevant, but the brain mets part is it does matter clinically.
Right. So that's one of the differences which is coming out in terms of brain mets. So that was the next question, but anyway, that's what you answered. So this is data from the brain mets patients. We have seen data that overall survival of these patients is very poor when patients present with brain mets. Median OS in many of the data sets in the chemotherapy era used to be somewhere about 8.5 months. And the Caspian, what you saw was patients in brain mets, the overall survival improved from 8.8 months to 12 months with a hazards of 0.69, clearly significant. And so somewhere you'd say even more significant than patients without the brain mets. So what it's clearly telling us is it is an effective regime. And as Dr. Anup mentioned, probably for brain mets, you have more data about durvalumab than you have about Atezo. So that's kind of looking and favoring it. I think Dr. Nikhil also voiced the same thought. So Nikhil, for brain mets, you are clear about, you are much more going to favor it?
Yes, sir. So with brain mets, I think there is data only for that. Although asymptomatic brain mets were included in the atezolizumab arm as well. I think 17% was the number, but definitely treated brain mets were not included in the trial. But durvalumab had that option of using treated brain mets as well.
Right. So there is this flexibility coming out. I don't think the drugs will be very different, and I don't think personally whether you use Atezo or Durva, it would matter that much. But you clearly have, in all these immuno trials, what happens is you end up choosing the drug according to the trial data, and that's the reason why probably Caspian would hold good a little more for patients with brain mets. So this is again emphasizing the same point that possibly all of us agree with this. Using this benefit at 2 years is probably significant enough, and all of us would kind of think of adding the immunotherapy to the chemotherapy in the first line setting. So this was the PFS data at 2 years, again talking that 10 to 11% of patients had not progressed at 2 years. Though these numbers quite small, sound very small, but when one needs to understand we are talking about small cell. So anything in small cell, when you start talking of 2 years PFS, it is remarkable in stage 4. There's really no doubt about this. And it's there right there in the NCCN guidelines. All the two combinations are fully approved depending on what you choose, and with the flexibility of using the platinum drug, whichever you want as per your choice. So Dr. Kushal, what are your thoughts about PCI in extensive stage small cell? I will come to some controversial questions here. So tell me, what do you do currently in extensive stage in terms of PCI? Do you do it or not do it?
If we are using only platin plus etoposide, and if at the end of treatments the disease is stable or responding, then definitely we should go with the PCI. But how the PCI will be useful in the era of the immune therapy, that is a questionable. We have not enough data to support to use PCI in either of IO plus chemotherapy combination. So if I use atezolizumab or durvalumab along with the chemotherapy drugs, then I will definitely omit the PCI in even extensive stage small cell lung malignancy.
So currently, but for your extensive stage post chemo, you do give PCI to your patients?
Not right now. I definitely omit the PCI in ES right now, a small cell malignancy.
Right. Okay. Dr. Uma, your thoughts on the PCI in extensive stage?
As you said, it's a controversial topic, but still, I don't routinely use it unless patient has a complete response. And secondly, if patients are going to be compliant, because there was this one Japanese study where they did do an MRI every 3 months and treated at progression versus giving PCI, and there was really no impact on the overall survival. The only the impact was in the incidence of brain metastases. So I may be a little conservative in using PCI in extensive stage small cell lung cancer.
Right. Dr. Anup, your thoughts? Do you use PCI? No PCI, extensive stage?
Sir, I generally use PCI. I think the brain mets, even though there might be no OS difference, but they are very troublesome. Seizures, then the morbidity. So I generally prefer to give PCI to my patient for extensive stage.
Right. So this is perfectly the way it is. It is very controversial. So Nikhil, your last thoughts on that?
So really controversial, but usually I don't go with PCI, sir.
Right. Okay. I think we went in the whole loop up and down. We started with not giving, and then the ECOG study came, and then we started giving to our PCIs after chemotherapy when they finished, and then the Japanese data came, and again we stopped giving.
Yes,
so yeah, it is very controversial. I would say depends on how well your patient has responded and what your aims in the patient are. But I kind of think if patients are going to survive long, and especially if the immunotherapy starts working and IO combination, I would say we would avoid PCI, because we really don't want the quality of life to come down with any of the CNS related problems due to the radiation. Now, again, I wouldn't say if anyone does it is wrong. It's perfectly correct, and each person has its own way of looking at it. So the other controversial question was again same thing. What about the role of radiation to the residual primary after you finish treatment in the primary disease in these patients after you treat them? So please tell me what you do with the chemo era, and what would you change with the chemo plus immuno era? Would it really change, or would you follow the same thing? Dr. Kushal, I'll start with you again.
Definitely, the question's answer is a little bit simple in a chemo plus immune therapy era, because we have immune therapy as a maintenance therapy after completion of the chemo IO combination therapy. That will take care of the residual disease, I think so. The questions is a little bit complicated in only chemotherapy options, but still in my personal, I am not using any local radiation therapy, the residual primary treatments at the end of the chemo therapy with positive response.
Right. Okay. I think that's perfectly correct. Dr. Uma, your thoughts?
I agree with Dr. Kaushal. I'm not using routine local EPRT to residual primary currently in extensive stage. I think there are a couple of trials which are going to answer both questions which are ongoing.
Right, you're right. Dr. Anup, you do? Yes.
Sir, I concur with the panel, sir. I don't use the local EPRT.
Okay. Dr. Nikhil?
So I don't concur with the panel. There are two patients of us, and I'm not sure if Dr. Weber Sonmani is on the line. He's the senior radiation oncologist. And we have actually given local EPRT, which is a very good response to the primary. And we can put them on maintenance. We had used atezolizumab. We put them on maintenance, then they're doing good. But again, I would ask, if we are giving local EPRT, then could you use PCI, or does the answer change to either of them?
So I'm a little non-PCI person. So I would kind of not use PCI, though local radiation I do use a lot in my extensive stage patients. So I agree with you, Dr. Nikhil. But my personal choice is if the patient responds very well and the local disease is very limited, I do give local radiation. But again, as Dr. Kushal and Anup and Uma mentioned, there's no really data to really back us in saying we should do it. So if you read the guidelines, they've worded it in such a way and so much detail, so you can interpret it the way you want to. So you can look at it and say that, yes, I would give PCI to a certain group of patients, and I would probably not give PCI to some patients. But yes, they have allowed it. It's not that it's not there. What I mean is, sorry, not the PCI, the radiation to the local area. So they have quoted about the Dutch CREST data, and they have said that you could use radiation selectively in your patients. So I think this would not change much in the immunotherapy era. This would be almost the same whether you do it continuation of treatment, radiate, and continue the immunotherapy. So this is the summary of the data sets. We've seen the Caspian data, how it is slightly different from the IMpower 133 of using Atezo, but we have seen the benefit. So I would like to take up individual experiences lastly from each person, and what their thoughts are, and what they have experienced with, if they have used the IO in small cells. So Dr. Kaushal, your thoughts?
No, definitely adding any of the IO, either atezolizumab or durvalumab. I have a couple of the patients in each of the drugs. They are doing quite well compared to the chemotherapy aspect. The quality of life is also maintained, and we can say that after the completion of the treatments, we can continue with the maintenance therapy. I am a little bit comfortable to use durvalumab as a treatment option because it does have a flexibility with the two platines, carbo as well as cisplatin, and to a certain extent, it is useful in the patient who having a brain mets, because small cell lung cancer have tendency to grow into the brain very high. And as Dr. Nikhil has mentioned that durvalumab as a maintenance therapy, we can consider every 4 weekly. So that is a little bit comfortable for a patient as well as to a doctor. And to a certain extent, economically, we have a higher age with durvalumab because of 4 weekly treatment. So these are my just summary of a concept.
Right. Thank you for that. Dr. Uma, your personal experiences of using IO in small cells?
I honestly, I'll be very, I have never used IO in small cell. Most of my patients have not been affording it. So so I don't have a personal experience of.
Right. No, that's fine. It's very recently approved, so everyone will slowly gain experience. Dr. Anup, your thoughts on personal experience?
Sir, no personal experience in small cell
Right.
extensive stage. Yeah.
Right, that's fine. Dr. Nikhil, your thoughts?
Sir, to be really fair, we have used IO a lot, and I do offer it in everyone. And although the data doesn't show it only shows a 2-month advantage. Actually, I find that advantage is a bit more, and people are actually doing very well. So, small cell, I think it is changing.
Right. I think you put it right, Dr. Nikhil. I personally would say this. We also are very IO centric. So we use a lot of IOs in lung cancer, and in small cells we offer it to all our patients. And we have used both the drugs now. I personally think there is a difference. It's very difficult to say in the first 4 months because your chemo is right there. So that's the whole problem with small cell. In non-small cell, you're still a little bit more confident in telling what is working, or maybe this is working better. But in small cells, we know the response comes from the platin-ETO. So there's that dramatic response. So we know that it's the chemo effect. So it's very difficult to kind of say that IO made a difference. But now as time goes by, we have a couple of patients who have actually crossed a year of post-treatment. And we have a couple of patients who took IO for a limited time and stopped IO. And the disease has not progressed even after stopping it for 6-7 months. They stopped for various reasons, financial or other things. But even after 6-7 months of stopping, the disease has not progressed. And I think that's where the difference lies. In all our older experiences, if patients who stopped the chemo, eventually you used to see them progress very rapidly and they needed to get back to some chemo or the other. But there are patients who are doing well long-term. So I think that's the essence of IO therapy for us. And that's where we'll be learning how to use it better. But I personally feel small cell is changing, as Dr. Nikhil has said. And IO will find a place. We may not be as happy as we were with non-small cells and other cancers, but we are definitely making some changes. And I think that's the best way forward. With this, I would like to thank all the panelists. Thank you very much for that interaction. And I thank AstraZeneca also for giving me this opportunity. Thank you very much.
Thank you. Bye.
Thank you. Thanks a lot.
Thank you, sir. Thank you, sir.
Thanks, Dr.
Thank you.
Aram, would So I think, Arun, can we?
Support team, can
So,
you mute everyone? Support team, please mute everyone.
So thank you again. Thank you, Dr. Amit, and thank you all the panelists for joining in. And it was such a useful webinar, I would say. And my special thanks goes out to two persons, Dr. Amol sir, for making it from the start, as in sir has been planning and sir has been so actively involved in this program, which has been going on since, I mean, the planning started really way back. And for us, being quite new to the scenario, sir has really helped a lot. And we cannot thank enough Horizon Conferences for being with us, for taking us through, for timing, making us find time for everything, and getting this program on board. Again, I'd like to thank everyone who participated, everyone who joined, and hope it has been a rewarding experience for you as well.
Thank you very much, Tarun and team. Thank you very much. It's been a wonderful experience for both the days. Superb speakers, very good panel discussion. I personally liked the last panel discussion. Thanks, Dr. Amit Rautan and Dr. Uma and all the other panelists. It was a wonderful, discussion. Since small cell lung carcinoma, it's sort of something neglected topic, I feel, but it's lot many things to discuss, and hopefully, we all get benefited extremely well with this panel discussion. And thanks a lot to all the title sponsors and each and every person here. Thank you very much, Nikhil, and thanks a lot, Tarun. Over to Nikhil.
Thank you, sir. It was you who drove us all the way. And Tarun, thank you again. So I think, Tarun sir, we can conclude.
Yes, sir. Yes, sir. Thank you so much. Thank you so much for the kind words. And I think we can conclude by saying thanks, good night, stay safe, and we hope we'll meet in the personal meetings very soon.
Thank you.
Thank you. Thank you, everyone. Good night, sir. Good night.
Good night.
Thank you. Good night.
Support team, kindly close the meeting. Hello.